considered beautiful, they were doing something to keep themselves looking beautiful also. We hear that they used to bathe in honey and milk and try to do something for themselves. So us zamane mein bhi there was something being done by which they were trying to look beautiful and their skin would be glowing, right? So now today also we have people who are, even in the regular markets you are selling maximum face creams and talcum powders and foundations and whatever. This is all why it's an effort for us to look good, isn't it? So all of us, I'm sure, are owning at least one cosmetic product with us, even the men, right? So it is a billion-dollar industry and we can sort of participate in some way in it, and that is why another reason to get into this facial aesthetics is because for dentists we are having a natural hand dexterity. Our hands are used to doing fine work in the oral cavity already, which is already such a small area, and then putting, carving out fillings and whatever else you do. So we are already having hand dexterity. We are already doing injections in the oral cavity. We are masters of the anesthetic injections also. We are, for every dental thing that you do, crown cutting or root canal treatment or whatever you do need to anesthetize the tooth sometimes because the pain should not be felt by the patient. Then we also have a great familiarity with the facial anatomy. I mean, no other specialty of medicine is dealing with the head face anatomy in detail as much as dentists do. In addition to the soft tissue part of it, we are focusing as dentists more on the teeth, and we have forgotten that the facial skin and muscles also can be enhanced by certain means. We are also should keep in mind that the face beauty combines very well with teeth and the smile beauty. So all of you go into post dentistry and you start learning about laminates and bleaching and how to make your teeth, crooked teeth straight. What is that effort? That effort is to make the smile beautiful, isn't it? So when we are learning those things, we are forgetting we'll straighten the teeth, we'll make such beautiful color, white color teeth, but the skin will have pimples, the skin will have scars, the skin will have pigmentations, and we are not looking at that aspect of it. So now we would want you to sort of combine both the things. You can offer both the services to your patients, and therefore we can try to learn a little bit about facial aesthetics. Now, to understand what you can do as general dentists, not everything is allowed to be done by general dentists. Remember this. So what we want to remember is that there are two types of procedures in this. There are surgical procedures and there are non-invasive procedures. So surgical procedures are something which will obviously be done by the surgeons and not by the general dentist. So let me see how these procedures can be listed. Now the surgical procedures, as you can see, are like rhinoplasty, which is your nose job, and it is one of the most popular cosmetic procedures done in the world. It seems everybody wants to straighten their nose or something or the other. They are bothered with the nose for some reason. And of course, nose is a very prominent structure on the face and is very visible to people. So they are very conscious of it if it is having a little, crookedness or anything like that. So they keep going for rhinoplasties very often amongst all the cosmetic procedures. And I'm talking about the surgical one, okay? And then we have the orthodontic surgeries of the face. They are definitely enhancing our features because if you have a prognathic mandible or a retruded maxilla, it doesn't look good on the patient's face. So he will do surgery to get his skeletal jaws corrected to the correct profile, okay? Then genioplasties, the chin is an important structure. Now when you look at a face, it is an important aesthetic structure. So if you have a less prominent chin, too weak a chin, and you want to give it a better shape, then there are surgical procedures which are done to correct that also. Then facelift surgeries for the older people, because by the time you get a little older in age, your skin starts sagging, so then they want to look a little younger. So then you have surgical procedures by which the skin would be taken back and sutured in the hairline. So the incisions are hidden in the hairline and they are done on the operation table with a downtime of 10 days or so. The bandage is worn on the face and everything. But once they come off, of course, the person looks good. Okay? So those are called facelift surgeries. Then liposuction fat removal. I'm talking only about head, face, neck. So we are talking about cheek fat removal, submental fat removal because you have double chin. So those people are conscious of that and then they try to remove that by liposuction machines and things. Okay? Plastic surgeons are dealing with the whole body, where they're obviously going to remove abdominal fat, thigh fat, wherever you feel you have excess fat, they will try to mold your body to the ideal shape in that sense. Coming to blepharoplasty, what is blepharoplasty? You can look at this picture on top of this lady. What happens to us is as we age, the upper eyelid becomes heavier, with the fold of the eyelid becoming, because of sagging, it becomes more, bulky, and it's sort of hanging over the upper eyelid, as you can see in this first picture over here. Okay, so blepharoplasty is so cleverly done on this lady. See, you can now see the difference between her eyelids show, because the heavy structure above has been removed, and it has been scissors से cut करके dissect करके रखा हुआ है, but the incision is hidden in the eyelid fold, so you cannot make out a surgery has been done. This is a very nice plastic surgery, but the change in our face from seeing this heavy fold to this is dramatic. Just by changing that, the person has started to look younger. Okay, this is a blepharoplasty procedure. These are not surgical procedures. Then we have under eye fat removal. Some people have excessive fat under the eye. That also can be removed surgically. Then we have dimple creation, which you must have heard of very easily. That is a chair side procedure and can be done on the chair. So these are some examples of surgical procedures which you won't do. So what are we going to do? We can learn a little bit of non-invasive procedures in which we use fillers for the face. Okay, if something is deficient, we fill it up. You can use neurotoxin injections to control wrinkles and hyperactive muscles. Then you have skin improvement procedures in which you can do tightening with peels, dermaplaning or dermabrasion. These are some kind of procedures which I'll just briefly explain later on. They basically will improve the skin surface areas of the patients. Lasers are very much in the market for this. You have lasers for hair removal, you have lasers for pigment removal, and lasers for skin tightening also. Now these lasers are, let me tell you, are usually different for different purposes. You cannot have all in one, though they are trying to make new machines which are going to do all the things in one. But because the depth of penetration of the laser beam is going to be different for different work, you will have to buy 2 or 3 different types of laser machines for this work. Then ultrasound devices are also available, radio frequency devices, and these are very good for lifting up the face because they create a tightening effect after it has worked on the face. Okay? Then microneedling is basically what it says. There will be multiple 24, 30 very, very tiny needles which are used to prick on the skin, because of which you are creating micro wounds, because of which again scar tissue healing takes place, and that becomes tighter skin, because scar tissue is basically collagen, and collagen is always going to be tighter than your natural skin cells, right? So this is how basically this all works in adding glow and tightening of your sagging skin. Then a little bit more invasive are the threads. These are subcutaneous threads which are inserted below the skin surface, and they are absorbable threads. They will be absorbed by the body or resorbed by the body over a period of time, like a year or 2. And in the meantime, when it goes away from there, in its place, it leaves behind inflammation, irritation, because it's a foreign body, and therefore the healing is again going to take place as it is resolving with scar tissue, which is again collagen. So when you get collagen deposited below the skin is going to be tighter than what it was before. That is the fundamental behind how it works. Now, in these facial aesthetic procedures, so we are going to look at the non-invasive ones, because that is what is there for the general people. We have 2 types of patients. We can have young patients who have some issues, and we have older patients who are obviously trying to remove the sagging skin and try to look a little younger. Now, look at this picture. You can see that we can do something like making this patient look from this to this. A little bit of blepharoplasty has been done, a little bit of filler on our cheeks have been added, because whatever volume is lost cannot be replaced by anything else. We can do fat transplants, take it from your hip or abdomen and put it there, but again, that's a surgical procedure. So here we can use it, just an injectable fillers are available, and you can see a lot of, little bit of neurotoxin also has been used. It's not that one thing has been done on this face, but you can definitely see her face looking so much better than it was looking before, right? So it's not one thing that works, you need to know everything and sort sort of mix and match for the person's face what is needed, and you do the process. Okay? So you can definitely see the improvement on her. She's definitely looking good. Now, other people who look good, even though they don't seem to be aging at all, the famous icons of our film industry, you know, Rekha is today 69 years old. But can you see any change in her from her youth? Look at the jawline, look at the nose, the lips, exactly same at 69 years of age. How many of us can look like this when we are aging? Only if we take care and we take the help of plastic surgeons or people who are doing non-invasive work. So if you are in the beauty industry, you can try to make your normal patients also look like them. Okay? So this is not without maintenance. Don't think that people can, you know, not have sagging skin and they are different genetics. No, they also have the same genetics. They will also age. It's just that they've been doing something all the while to take care to look good. Like that. Another example, Kareena Kapoor. Look at her youth. This is her first movie. Sorry. This was her first movie picture of her when she probably launched into the film industry. So you can see how young she looks. She looks good then also. But now she's not looking bad at 40. In fact, I would say she's looking better than she was when she was 20. So what is working for her? You know, let us see. Look at her cheeks. They are much more prominent now than they were before. Her lip is still good. And I'll tell you why I'm highlighting these features to you, because I'll tell you what happens in aging. Everything is lost. Our lip is not going to remain the same as it is now in your face today at 20. When we are 40, the lips change because the volume is going to change. Okay? And that cannot be stopped. And like that, we have so many other examples of other actresses from there. I'm showing you the before and today's pictures, and you can see none of them are looking bad. They are still looking great, isn't it? All of you agree? Yeah, they're looking better now than they looked in their youth, in fact. So what happens to make a face look older? Okay, one is we will start, our skin naturally starts thinning as we get older. We start getting hyperpigmentation because we are exposed to so many years of pollution and sunlight. So we are going to get some amount of pigment on our face, and so that solar damage will add up, and so we might have little discolored looking skin as we are aging. Dusra, there will be progressive tissue laxity. We are going to have loose tissues and lose its volume, and we are going to also have brotosis, which is what I said, the eyebrow keeps falling downwards and the eye starts looking little heavier, and because of all this sagging, you will start having, you will start having this nasolabial fold, okay, which is going to form prominently on the face. Now nasolabial fold is this fold which is in front of the, or next to the nose going down to the lip. This becomes prominent only as you become older. Now after this lecture, you can look at each other's faces and then go out and look at some older people's faces, and you will see what I'm trying to make you notice now. Abhi tak aapne uski taraf dhyan nahi diya tha, but after the lecture, maybe you start looking at these faces and start appreciating what is adding to the aging factor and all, right? So what happens to us naturally, physiologically, is that in a youthful face, we have a lot of fat. In an older face, this fat starts reducing in number. You just can't stop it, it's going to happen. Okay? Also, our, the muscles of our face are going to become thinner as we age. Even the bone starts resorbing. You know about the mandible and maxilla resorptions because you talk about dentures. But let me tell you, look at the cheekbone here. The zygoma is the most prominent feature for us in terms of external beauty of the face. And you can see this older person, the diameter, you can just see the size, the zygoma is also reduced. So bone also reduces in size. So overall, when you have fat, you have muscles thinning out, you have bone thinning out. So what will happen? The skin has no cushion. The jo stuffing andar hoti hai wo khatam ho gayi. So what you're going to have? Flattened. And then what? Gravity is going to work, and gravity is going to pull it downwards. So we have sagging happening because of this cheekbone height itself reducing. And then where is this sagging going to be seen as? It's going to be seen as a prominent nasolabial fold. And you're going to see jowls in the middle of between the angle of the mandible and the chin. Here you see tissue hanging out. Okay, that is called jowls. So this is what gives a person an older look. Now look at this comparative face of the same person at young age and the same person at an older age. Whatever I was telling you, that you can appreciate here again. Let's start from the top. You can see the eyebrow has turned down a little bit, and this blepharoplasty scene has been created over here. The upper eyelid has become heavier, okay, because of sagging skin. You will have wrinkles on the eyes, you will have wrinkles on the frown areas, you will have wrinkles on the horizontal lines of the forehead. All this lying around start giving the person an older look. Then you come down because the cheek height is subtly reduced. So this whole skin is sagged downwards, and this jawline has disappeared because you have loose tissue hanging over here. These are called jowls. Okay? So this is what happens, and the nasolabial fold. And please look carefully at the lips. I kept on telling you lips have not changed for the actors. That means 100% they are using some amount of filler to keep it plumped up, because when we age, the fat in our lips also dissolves, and we have thinner lips as we age. And if you let them remain thin, they give that overall image of being older. And if you fill up the lip, the person will start looking little younger. Okay, so when we know what is making a person old, so the treatment is to do the reverse. Turn the lip upwards, fill it up a little bit, because the corners of the lip also go downwards in an older person. Okay? Now when we look at a good-looking face, young face, we are looking for facial symmetry. Both sides, left and right, should be same. If there is some disparity, immediately the face doesn't look attractive. So apne aap, our eyes is locking on to the fact that the face is symmetrical or not. And then we also, again I repeat, I've been telling all this while, the bizygomatic width has to be the widest portion of our face. Now these proportions were decided to be called as golden proportions. We don't just design a face like you do smile designing. We know about what should be the size of a central incisor, what should be the width of it. You should know what lateral and canine look like. Then only you fit it to a particular face and you do a face or a smile designing also. The same way we have certain norms for the face also. So one of the norms that I'll not go into detail, but little bit you have to understand, basic thing is that my bizygomatic width has to be the widest portion of my face. Okay, so if I have narrow cheekbones from birth or whatever only, that means I'll not look as good or proportionate as a person who has wide cheekbones. That is why you're seeing Karina with more developed cheekbones now, right? And then we should have a bigonial. What is bigonial? Sorry. Bigonial is the angle of the mandible here to the angle of mandible there. Okay, that width has to taper down for a woman about 10 to 20 degrees downwards. The girl who has very wide bigonial width is having a square face, and she will look a little manly. This is how we appreciate beauty. So if a woman of that proportions comes to you, you know you have to reduce her bigonial width and she will get her balance. Or if you can't reduce the bigonial width because of some reason, then you maybe widen her cheek so that it gets the higher proportion and you get that taper over there. So like that you have to analyze the face ki karna kya hai agar somebody comes to tell you make me look better than I am looking. And the chin has to taper down to a nice pointy triangle. So in a young patient, we have an inverted triangle with the base on top and the chin being the point. Okay? Then in an older person what happens? All that sagging went down. Now no triangle. We have a trapezoid because cheeks are flattened and all the weight has come to the lower half of the face. So instead of having a triangle at the base, it looks as if the chin is too wide because the jowls have added on the weight of that and it looks like part of the chin. So it has become so much wider. So now if I want to make her look young, I want to get back that triangle with the base on top. Simple funda. So I have to build up the cheeks, and when I build up the cheeks, the skin will become a little tighter and it will be pulled upwards. When it will be pulled upwards, this jawline becomes more defined. This is how simply some things work in this field. Okay? So where to fill is the way, and where to reduce is the thought process that we have to apply. Now, these non-invasive facial techniques basically aim to do these four things. They will resurface. Suppose you have discolorations or things, then you want to make the surface shining and glowing. So you will use some means to do that. Like peels are an example of using some chemical acids on the skin to give you that shine, because it strips off the dirty skin, the dead skin cells, and will take out the new growing skin cells. It causes a regeneration of new cells. Okay, so that is called resurfacing technique. So example, peels would be that. Then we refill some areas which are deficient. Like I said, cheekbones have fallen flat, you fill it up. If you feel chin is too small, fill it up. So you get a more prominent chin. Like that, you have to decide where is the deficiency and you can use the fillers to fill up that area. In case of relaxing, there are some muscles who are causing wrinkles, for example. Most commonly the upper face. For example, the frown lines. All of us, even for concentration, not just for anger, we are showing frown lines. And then raising eyebrows is going to continuously happen as one of our facial expressions. So we are going to have horizontal lines created on the forehead. Now, initially when we are young, our skin is so elastic, full of fat below it, that it bounces back. It's having elasticity. So muscles act, but they don't leave any mark behind. But as you reach your 40s, then all that under se dissolving shuru ho gaya. So now these muscles are going to leave, they are continuing to do their job, but they leave behind permanent lines now. So we have something called as dynamic wrinkles, which the young faces have. If I tell you to do frowning, you will also have it. But it goes away when you don't frown. And it is not visible in a relaxed face, right? In the young people. In the older person, even if they have stopped frowning, the lines have become permanent. And then they are called static wrinkles. So now there is a different way of handling both. Both mean you will need to give relaxation of the muscles. You will have to inject neurotoxin so that it, sort of stops the action. What does the neurotoxin do? It will basically paralyze the muscles. So you want to target it in certain areas and inject in those key muscles. You don't want to inject the wrong muscles because you might get a lopsided smile, or you might get a, like half forehead is wrinkled and half is smooth. You can have all those kind of disasters. So you need to learn where to give the injection so that you are getting a nice smooth result. Because of these, wrinkles would be not happening. There are other ways of using, I'll show you them in pictures also, of using the toxin. By the way, a neurotoxin, which in other words you may be knowing as Botox. Okay, Botox is a brand name for the neurotoxin. There are many brands in the market, but Botox has become famous, so everything is Botox now. But that's why I'm avoiding using the word Botox. Now, neurotoxins in our oral surgery field have a lot of other medicinal uses. This is only facial aesthetic one that I'm talking about, but we use it for many, many other diseases in which we need to control the muscles of our face for whatever reason. Even myofascial pain dysfunction, even trigeminal neuralgia, we are starting to use neurotoxins now to handle the disease. Okay, that is a new trend in it. So next thing is redraping. Redraping means वही आप खींच के उसको जो नीचे आ गया है उसको ऊपर ले जाओ. So for that mostly we have something called as threads, which we'll insert subcutaneously. I'll show you some pictures of roughly how they are inserted so that you know that is done. So that is a little invasive, but next. Okay. Now coming to the pictures of before after of relaxing muscles. When we use a neurotoxin, you can see those horizontal lines of the muscle forehead I was telling you about. Once it is eliminated, see how smooth the forehead looks, and the person automatically looks younger. Now obviously this is to be done in an older person, but before the wrinkles become static. You should start, if at all somebody wants to really maintain, and I'm talking about hardcore maintenance. I'm not saying you start doing it now or something, but the point is that those who are in the film industry or who are modeling and such things, at 35 itself they'll have to start using it, because by 40 the lines will start becoming visible, even if they are not frowning over it. Right? So they do start using it in time, and then you can see the crow's feet, which is this, around the eyes, because we do crinkle eyes for every expression. So even there you get permanent lines, so we can stop the muscles acting, and you don't notice any change in the patient's face work, except the fact that it is smooth, that's all. And you can see this frown lines on this lady, which has been made smooth now. So this is how we relax the muscles. Now coming to uses of, this is multiple uses. Now again, this patient is not a single, procedure usage wala improvement. There's multiple things being done on the patient. To see this, initially if you see this patient had little discolorations also. Now it is having no discoloration. So little bit of lasers, little bit of peels, little bit of fillers, a sort of mix and match has been made for the patient, and you can see the lines are also disappeared. You can see these folds have gone. Look at this person's neck, it has improved. So these kind of things are adding to the improvement of the patient also. Coming to refilling, I told you we use fillers basically where we feel the volume has been lost, and most common place the volume is lost is the cheekbone. So we are going to try to build up the cheek, build up the cheek in this patient, and immediately you will notice one subtle change. When we add volume in this area, this nasolabial fold also has decreased because the cheek has lifted it up by pulling up the volume. So apne aap kuch after effects will happen to the other parts of the face also. And this is what you're seeing in this also. You can directly fill these, these lines which are here. You can use filler to fill that also, but nowadays that is not much recommended. I mean, I'm not teaching you the basic science which has to go into it. I'm just covering it superficially. So a decision making whether udhar bharna hai ki nahi bharna hai is something what we learn when we are training you for all these things, okay? And but you can see the improvement in the face. Undoubtedly, the person is looking so much better. Then we have re-dripping. I told you we use subcutaneous absorbable sutures. They are the same sutures that a normal surgeon uses when he is closing up the layers, inner layers of surgery. You have heard of them? They are the same sutures. Only thing is they come along with their own cannula. They are inserted inside, and then the cannula is removed. The thread remains behind to irritate, because it's a foreign body in a way, and then it will cause irritation, will cause inflammation. Inflammation will cause there will be enzymes coming to try to dissolve that thread, and then you will have healing with scar tissue. So therefore the scar tissue is going to be a little tighter and stronger than the regular subcutaneous tissue that existed before. So immediately the patient's face becomes tighter because of the inbuilt collagen that we have created. So we may have to use hundreds of threads, by the way, not just 5 or 10. If you really want a lot of improvement, there have been cases, I mean, in Korea, this process it has come from Korea. Actually, this trend has spread from Korea only, these threads. Now, these threads have, in the Koreans, it's so popular that they will use up to 140 threads per face just to look young. So you can imagine how popular this process is over there. And it works, because they are the leaders in this particular thing. Now, coming to the younger faces, basically younger faces have only few things to look at. One is that they may want a little higher cheekbone, so you will anyway fill the area so that they get this more prominent cheekbone, model face look, as they say. Another area is lips. If they don't like your lip shape, then they can be helpful. Some people are born with very thin lips, so you can always help them with a little bit of volume over there. It should never look excessive, obviously, otherwise it's going to look odd and the whole world is going to start commenting on you. You are supposed to do just the right amount of aesthetic work which says the person looks natural rather than somebody telling you, tere saath kya ho gaya, and all that. That kind of thing should not happen. So you can see these lips have made this girl look so much better than before. A lip filling may be science. Kitna bharna, kitna nahi, that also I'll briefly go through later on. Now here is another woman. She has some very little unusual problem. She is having temple hollowing. Sorry, pressing the wrong button. Temple hollowing. In the sense that this area is having less muscle mass or whatever from the beginning. Some people are there, a little skull look, maybe thoda patle rehte hain. So that doesn't look very aesthetic. So we can just fill. Once it's filled, you can see she is looking so much better. You can see the before after in this also. Then there are a lot of complaints of under eye troughs. There are depressions under the eye. That can be filled. Okay. Then it immediately, when you have these depressions under the eye, it also gives an impression of having dark eye circles. So when we fill it up, the skin stretches and the darkness also goes away. अपने आप ये दोनों चीजें इसके साथ handle हो जाती हैं. So this is also another very popular area where the fillers are used, under eye fillers. Okay. Same thing with the other girl also. She is also having the same problem, and it has been very subtly filled. You can't make out also that it's been filled, but you can see the difference in the before and after. Then we have skin surface improvement. I told you if you have pigmentations and scars left behind by pimples or whatever, then they can be targeted by using various things like peels or even lasers which remove pigmentation, and you can get an improvement in the face. Then managing gummy smiles is part of neurotoxin. It's very simple. You target this first case you are seeing here. When she smiles, you can see a lot of gum. But when we control the muscle which lifts the lip, then even if she'll smile, like she's smiling naturally only in the second picture, but now her lip is not going up as much as it was going before. And it was with the simple 2 injections in key areas, and that's enough. For 1 year she has relief of, she'll have to repeat it. Of course, neurotoxin is not permanent, you need to repeat it every year. Another one I was telling you is the jawline shape. For a girl, if you have too wide gonial angles, it's not going to be good. So we have something called as, again use a very simple injection on the chair by neurotoxin, which paralyzes the masseter muscle, which is the muscle here, which is prominent. And we just paralyze it by 2 doses of it over a period of 1 month. And then the muscle, because what happens to muscles which are paralyzed? They undergo disuse atrophy. They will slowly shrink. So that is what we want the masseter to do, to shrink. Ek zamana tha, if we had to handle it, we would have to take a incision and then literally trim it and see kitna patla hua surgically. Now we have an injection. It is so easy and it can be repeated again after some time. So this is a very popular area for which we can use the muscle, the neurotoxin. Then hair removal, you may have heard of permanent hair removal. So we'll use lasers for those who don't want to regularly every week pluck out their hair. So that is both men and women. So these lasers are giving almost 95% success rate in eliminating all the hair. Okay, it goes down to the hair follicle and kills it, and then, but still, either 95%. So 5% hair still remains behind. Don't ever say 100% to the patient. But that 5% is so negligible to see that they hardly will, roj ka wo kaam karne se, they are having relief that you don't have to bother with the hair again. So you can use it then on any part of the body, by the way, arms, legs, underarms, back, chest. Men use it for their chest also. So then we have lasers for, when we have pigment removal of the skin, obviously we are going to be able to remove the pigment of your tattoos. So somebody wants to remove the tattoo that they have made, then they go and get it eliminated. But none of these things will happen, even this melasma or any dark skin pigmentation on the face. Remember, it is not a single sitting procedure ever. All these processes take at least 6 to 8 sittings. All of them. If you want to see the results, that is the first thing you tell the patient in the OPD, that is going to take, even peels. It's going to give you an improvement after consistent doing it every month. So if you want the hair to be going, every month you will be targeting that area with lasers. It's not that ek baar dala or magic ho gaya, not like that, because hair will grow back again. Okay? So you can see this laser working on this pigment removal. And then I told you about recontouring and refilling the face. I said there is a science behind this proportion. We just don't see somebody and just do anything. We have to see overall the picture of the person and decide. And there are different norms for the men and different norms for the women, of course. That's understood. All these norms are given to us in our orthodontic surgery chapters, but we didn't pay attention to it. Now this is what, you must have seen these pictures. We divide the face into fifths, and we need to have each fifth equal to each other. Symmetry, of course, should be there. And we also divide the face into thirds. So we need to have equal thirds again in this. So if any proportion is lesser than that, let's say upper thirds are equal, but the lower third is less than what should be the size of the upper and middle one, then you know the chin area is for some reason deficient. So we may have to grow it vertically. Not bring it forward, but maybe grow it. So we look at it from the front view as well as from the side view, and we have all these calculations given in our textbooks in orthodontic surgery already. But we as, you might say dentists, or for that matter even oral surgeons, we were not paying attention to the face and its proportions and the soft tissue part. All this while we were focusing on teeth and designing and all those things, we were doing major orthodontic surgeries, but we were not really doing the subtle changes on the face. So now oral surgery has also included facial aesthetics and hair transplantation into our syllabus of PG in oral surgery. So we are legitimate workers in this particular field. Okay? Now I was telling you, for example, lip के पीछे भी थोड़ा सा सोच समझ के काम करना पड़ता है. For example, we should know that the upper lip is always thinner than the lower lip. So if you fill up the upper lip equal size to the lower lip, the person is going to lift a lot. So what is the proportion? 1:1.6. The lower one is supposed to be 1.16 bigger than the upper lip. So keep that proportion in mind when you're filling anybody's lips. Another thing that you keep in mind is you should have a very sharp vermilion border. Okay, you should have this philtrum well defined. There are lips without this philtrum also, but this is the beauty, the ideal. Okay, and there should be prominent cupid's bow. And you should have upturned corners. That's important because in a older person it turns down, or in any sad person also, he is all the time in a sad mood. He is also going to keep his face down like this. So remember, the smile is the most important thing of our face. If we smile at people, people automatically, even if they are strangers, will smile back at you. This is something so winning. So why would you want to keep your corners down? It gives you a sad face always. Even if you're young, it's not your relation to old or young. It's what expression you keep on your face. If you keep a happy expression on your face, you're going to be happy. And others are going to feel happy to interact with you also. It's the same little psychology what Dr. Deek was telling initially, the same thing. Okay, so we do want to make sure that our upturned corners are also paid attention to, and if they are downturned, you can fill a little corner area with a filler, and then you immediately get them to look up. Then, who is having the most beautiful face in the world as per these, proportions, golden proportions, for the lip, for the cheeks, for the nose, for the eyebrows, for the forehead? ऐसा हर एक का एक area है calculations का. This USA model, she's called Bella Hadid. Anybody has heard of her? She's supposed to have the most beautiful face, but even she is averaging only 94% as per the norms. Okay, and Aishwarya is around 91%. Okay, so this is what a beautiful face is supposed to look like in proportion. Then we have something called as chin assessment. Even for chin filler, if I have to decide I want to fill this chin, for example, this girl, when I look at a profile view, I obviously see this. There are lines to be drawn on the face of her face to decide how many millimeters to fill to get that proportion. So when we fill it up, you can see, this is not surgery I'm talking about, this is the filler effect only that is happening. Self-filling with hyaluronic acid fillers, and you can see her profile has improved quite a lot. And like that, we have cheek assessments. We need to have this small S curve, okay? We need to have this S curve for a cheek to look plump and good than when we look at it from the side. Now in this particular case, actually, you can see that it is depressed. It's having a concavity, which is not okay. And you can see that everything is wrong with her. Her lip, upper lip should be ahead of the lower lip, but it is in profile behind it. So therefore, in this case, no filler has been used, by the way. This is a more of a orthodontic surgery case in which the maxilla was deficient and it was a little retruded. So it has been brought forward, and just by moving the maxilla forward, the lip has come forward on its own, and the cheek is also filled out on its own because the maxilla was, left-out one osteotomy was done and it was pulled forward, right? So you can see that dramatic change in her soft tissue profile also because of orthodontic surgery. So we have to assess cheek also sometimes like this. Now, ending with beauty is in the eyes of the beholder. There are so many beautiful women photographs here from different parts of the world. So you can see some Britishers, some Africans, some Saudi Arabians. Oh, sorry. Saudi Arabian, Indian, Chinese, Korean, Scandinavians, all are beautiful, but the features are so different. The eye shapes are so different, right? But if you calculate their fifths and their thirds, they will all be same. That is what is golden proportion. So it's not the race and creed and caste which is deciding it. It's that whether you are having your fifths and thirds in that particular proportion or not. So you can be of any, you might say, race, but still you have these proportions on their face. And that's why the bizygomatic width and the bigonial width, if you look at their faces, they are all having that taper, right? Look carefully. Whatever I taught you till now is all there. So, in short, I wanted to say, concluding by saying that yes, you can do it. Only thing is you have to obviously learn it as a science, no shortcuts. It's as much theory to learn in this as any other field. And there are complications, why not? Everything has a complication. Even your dentistry has a huge list of complications. So everything has to be mastered properly with proper theory, and then you can really do good work even as graduates in the non-surgical aspects of it. Okay? And so therefore non-surgical procedures can be learned very easily by even the graduates. So thank you. And thanks again to CynoDent and team for allowing me to speak today.
Thank you so much, ma'am, for sharing your profound knowledge with us. Your session was full of zeal and valuable information. Thank you once again. Now, I would request the delegates who have registered with hospitality to proceed for the lunch one by one, and we'll continue with the sessions ahead.
Madam, I have one question. Madam, if we reshape the lip, so our lip pattern may also change.
No, we are not supposed to change the lip pattern.
Because we cannot individualize the person with the help of lip pattern if we reshape the.
So we don't reshape, we refill. We sort of re-volumize it because we know that it will
patterns will remain shaped.
Yeah, we will have to follow the shape of your, whatever is your natural lip. If your filtral pattern was not very clear, suppose in the initial stages, I cannot make you a filter. That I can't change, but I will follow your outline in such a way that I make the margins clearer, I give you a little volume in the lip, and of course I try to see that it is proportionate, that ratio between upper and lower lip should
Means patterns will remain same.
Yeah. If you try to change a person so much, no. Then you will find that they look very artificial. You can really make out a
Forensically use the lip pattern for individualization of the person. That is why I am
you are
asking
using,
about.
yeah, so when you see lip pattern somewhere, you can see even those vertical lines are supposed, I have not done forensic level understanding of it, but they have vertical lines on the lip which
vertical, branch, horizontal.
They are having another study in itself. हमारा जो level है वो level का नहीं देखता है कि वो lines कैसी shape के हैं.
Thank you, ma'am. Any more questions for ma'am? Thank you so much, ma'am. Oral Medicine, Diagnosis and Radiology, Rishraj Dental College, Bhopal. So please come on the stage.
You made an announcement for the lab.
Yeah.
Before we go to CBCT, I just want to show what are the limitations of your 2D radiograph. You'll say, I have just listing the 4 points, and the first point is 30% of bone loss is required before it can be seen radiographically. That means अगर आपने पेशेंट का पेरियापिकल रेडियोग्राफ लिया हुआ है और उसका डेंटल कैरीज दिख रहा है, उसका 30% एक्स्ट्रा डिस्ट्रक्शन इज ऑलरेडी देयर इन द पेशेंट्स माउथ. ओके, सो वो एक्सेस ही रहता है पेशेंट के मुंह में. So it is not giving you a clear picture. That's the point number 1. Point number 2, I already explained you that the third dimension is not seen. There is always an overlap of the structure which is there. Your palatal and your lingual structures are always superiorly placed. If you have ever seen a OPG or a panoramic radiograph, the X-ray beam goes like this. तो जो palatal structures रहते हैं, palatal on the maxilla and the lingual structures in the mandible, they are always superiorly placed. ऐसे रहता है. So it is not giving you an accurate position of the bone. So that is one of the limitation. And in the last limitation of panoramic radiograph is you don't get life size images. Life size images का मतलब है अगर ये 10 centimeter है, panoramic radiograph में ये 10 centimeter नहीं रहेगा. This would be either a 9 centimeter or 11 centimeter because there is always a magnification factor which is there in any machine you take of panoramic radiograph. So you don't get a clear picture even of this. A 10 centimeter का image हमें नहीं मिलेगा. So this basically forms your limitation of conventional radiographs. Okay. Can anyone tell me the historical importance of this radiograph? अगर आपने dental radiology पढ़ा होगा तो final year में or third year. It was the first human radiograph taken. Right? And this was done by Wilhelm Conrad Röntgen. He was the discoverer of the radiographs. और ये जो radiograph लिया है, ये उनके wife का है, Mrs. Bertha Röntgen. You can see a ring in her hand, right? Now, have you ever taken a radiograph? किसी ने लिया है IOP? कितना रखते हो exposure time? Tentatively कितना? It would be in seconds, right? You know at what exposure time this radiograph was taken? Any guess? Wild guess? 1 hour would be was too much. It was actually 25 minutes. Okay, so 25 minutes को डॉक्टर रॉन्जन ने अपनी वाइफ का हैंड ऐसे रखने बोला. उस जमाने में you have to place your hand or anything which is a radiograph has to be placed like this. ये source रहता था, वो phosphorus plate रहता था. Now if I tell my wife कि अभी तुम्हें 25 minutes ऐसे खड़े होकर रहना है, मेरी हजामत हो जाएगी. Right? So 25 minutes was the time to expose a simple radiograph of your hand. Now with the advent of CBCT, at my diagnostic centers or when you take a scan, in 14 seconds you can scan your entire maxillofacial region. I'm telling you the entire maxillofacial region. I'm not pointing to a specific tooth or like this. In 14 seconds you can scan the entire maxillofacial region. So that's the difference in the technology which has happened when it was discovered in 1895 to the year 2022. So that's the difference, huge difference which you can see, and that's the advantage of the technology. So I welcome you all to the world of cone beam computed tomography. That's the abbreviation for CBCT. It's a cone beam computed tomography. And this machine was introduced for the entire world in the year early 2000. In India it came somewhere around 2006-2007. The first machine was installed in Delhi. So when the machine came, the first question all the general dentists and people were asking, is it the right time to use this technology? Okay, एक नया iPhone i13 आता है या अभी सितंबर में i14 आएगा, आप पहले सोचोगे मैं पैसे खर्च करूँ या i13 i12 पे चलने दूँ. Obviously a common question because it's an expensive technology. But now in 2022 when we are there, I feel this question should not be asked because the answer should be yes only. Because CBCT has penetrated every aspect of dentistry. When it came for the introduction in 2000, it was just for dental implants. In 2022, the maximum usage for CBCT in today's time is endodontics. Implants is number 2. We are using CBCT for orthodontics, for periodontics, and we are using it even for our sleep apnea patients now. In fact, we are just have a patent in my name where we have started taking CBCT of hand wrist in the dental machine itself. So we can do an age assessment on a hand wrist also. So this is the thing I want to tell you, that when you venture into your practice or you're going to do your post-graduation or study or teach in your colleges, use for research, CBCT technology is going to be useful in every aspect. So you have to accept this thing. This is the application I've already told you. In today's lectures, obviously we are going to just concentrate on our endodontics part. Abbreviation of CBCT, I told you it is cone beam computed tomography. And why it is called so? Because it is just, you can say, a predecessor of CT scan. CT scan में fan shape की beam आती है, CBCT में cone shape की beam आती है. That's why the name is called as cone beam computed tomography. I'll just skip this. I'll just show you the two gentlemen who has given us the CBCT. They both are actually not dentists nor radiologists. They are actually biomedical engineers from Italy, and they are the gentlemen who gave us this machine. And the first machine which was introduced was Newton VVT, and it looked like similar like a CT scan. If you have seen a CT scan machine, it's just similar like this. Patient को लेटना रहता था और gantry में then the scan has to be happened. Now in today's time we have machines where you can stand, getting radiograph on standing. You can even make the patient sit and take a scan. It depends, depending upon the company which is. And the machine, the rays which are coming are like this. So here you get a cone-shaped beam, while in a CT scan you get a fan-shaped beam. That's the reason it is called as cone beam computed tomography. Advantages, I'll just quickly tell you. As I already told you the first one, the exposure time is less than 14 seconds, so you can quickly take the radiograph, take the scan. And because the exposure time is less, obviously the patient movement is also less. अगर जितना ज़्यादा exposure time रहेगा, patient हिलने के chances ज़्यादा रहते हैं, right? So उसके वजह से you get a decreased sharpness, you get decreased distortion because of CBCT. But the most important thing for patient is that there is a decrease in your patient dose. Dose का मतलब है radiation dose. And I'm comparing this with CT scan. I'm not comparing this with periapicals or panoramic radiographs. Periapicals and the panoramic have less radiation compared to your CBCT and CT scans. But when you compare between CBCT and CT scan always gives you more radiation dose, which is harmful for the patient. CBCT will give you less radiation dose. So that's the advantage for the patient. And for us, the advantage as a dentist or as a radiologist is we are getting something called as isometric voxels. अभी थोड़ा सर से ऊपर जा सकता है. So I'll just explain you in a very simple term. Now this room has three axes, X, Y, and that's the oblique one is the Z axis, right? So in a CT scan, when we take a scan, the X is equal to Y, but the Z axis is not equal, it is unequal. We have to do certain programming after which the X is equal to Y equal to Z. That happens in CT scan. In your CBCT, what happens is, even at the first exposure itself, your X is equal to Y equal to Z. आप बोलोगे इससे हमें क्या फायदा? Well, the biggest advantage we as a dentist get is that we are dealing with finer structures. We are dealing with dental caries, we are dealing with small pulp root canal spaces, we are dealing with small orifices, we are dealing with the pedial space, we are dealing with lamina dura, which are very narrow structures, okay? So to observe those narrow structures, you require a better resolution. आप कैमरा लेते हो तो better resolution कर लेते हो ना? क्यों? Because the image should not pixel it, you should get a better clarity. So this is what CBCT offers you. It offers you a better resolution so that you can see the finer structures. So that is the advantage your CBCT gives you over a CT scans, and that is an isometric voxels. So that brings me to the next concept which you may be dealing gradually when you start prescribing CBCT is, now suppose you have a patient for endo scan. endo करना है, उसके लिए आपने बोला कि चलो इसको CBCT लिख दे. You write a CBCT endo. Now when this patient goes to the diagnostic center, the machine has different FOVs. Now here FOV means field of view. और एकदम simple language में आपको कितना area expose करना है उसका नाम है field of view. So if you just want to expose two teeth, we do it in a smaller FOV. अगर हमें पूरा jaw चाहिए, we expose it in a larger FOV. So that's the only concept which you have to understand. So have you ever seen a panoramic radiograph and IOP कभी एक patient का कभी compare किया हो एक periapical और panoramic radiograph? I think the postgraduate must have experienced it. So which has a better resolution, a periapical radiograph or OPG has a better resolution? Periapical, right? So similarly, when you are doing with a larger FOV, उसका resolution कम रहेगा. But when you do it in a FOV which is very small, उसका resolution ज़्यादा रहेगा. So whenever you want to see finer structures, it is always better to do a scan in a smaller FOV, and that is the precise reason why you require small FOV in endodontics. Why? Because we require to see the finer structure, the root canal spaces, the pedial spaces, the lamina duras. These are all finer structures, and these can only be seen with your smaller FOVs. So this is how your CBCT looks like in endodontics. Okay, we can do everything nowadays on CBCT, even in endodontics. I'll just skip this, yeah. We just see a definition of diagnosis. It's because it's my field, where the definition is the art and act of identifying a disease from its signs and symptoms. And when we do a proper diagnosis, whether it's a periodontitis or pulpitis, we send the patient to the endo department to do the necessary treatment, right? So here, sometimes even in the endodontic department, sometimes there's a confusion of the diagnosis is there. And so we require a pinpoint diagnosis. What is the precise diagnosis? And then that is where your radiological tools will come to your help. Learning from others' mistake is wisdom. And waiting to learn from your own is ego, okay? So that's the proverb, and I'm showing you this because these are the routine cases which we get at a diagnostic center. Can you see this GP material? That has gone into the maxillary sinus. See this. Your entire root canal filling material. Why? Because the dentist was not able to negotiate the canals, nor he was able to appreciate the anatomy properly. Can you see this? क्या लग रहा है इसमें? इस डेंटिस्ट ने रूट कैनाल फिलिंग को पूरा मैंडिबुलर कैनाल में पुश कर दिया है. I got this case from Bangalore. It's almost a 2012 case, but still one of the worst cases I've seen in endodontics. And the problem what happened is because the patient was having a root canal, he was having a long-standing periapical infection. So and dentist ने root canal करने शुरू किया, but he didn't realize on the periapical radiograph कि नीचे periapical infection की वजह से जो नीचे mandibular canal है उसका covering पूरा निकल गया है. So when he injected the root canal sealer, it just went from the canal into the mandibular canal. So उसका पूरा patient का canal was painted with your root canal filling material or the sealer material. Okay, and the patient was having severe paresthesia in those times, and that's the reason the CBCT scan was done. And in today's time, there are medical legal aspects also. So it is always better if sometimes even a simple case can get into a bigger complication. So your radiographic diagnosis is very much important. I'll just skip this. Yeah. So what are the indications? Where should you use CBCT? I am a maxillofacial radiologist and I will never advise कि बाबा हर चीज में आप CBCT करो. No. Wherever you require, you please take a periapical, bite wings or panoramic. हाँ, उसके ऊपर अगर जरूरत है, then you always take a CBCT scan. And there are some specific indications. Assessment of root canal morphology. If you feel there is a missed MB2 canal or an additional canal, better to go for a CBCT. Vertical root fractures, not very easy to diagnose on your conventional radiographs. That's where CBCT is there, and this is much more common when you do a root canal treated tooth. And then almost 10 to 12-15% times the patient will complain that after root canal, if he has not placed the cap, he'll say that I am having pain. And those are the patients which are having a vertical root fractures. Detection of root resorptions, periapical lesions assessment, and in cases of endodontic surgery. So these are all the indications which you can use cone beam CT. So let's begin with the first case indication, and that is assessment of your root canal morphology. This is what is called as CBCT. Have you ever seen these images? This is a C-shaped canal. See the clarity. This is a small FOV scan which we have done. And now just look at till the end. We are going from the coronal region to the apical 1/3. Can you see two different exits? Very nicely you put exit. See this, those exits. So that is where you have a single canal, two canals, in fact two orifices, and gradually in the end they are separating separately. Now these things you cannot easily locate on your conventional radiographs. You may require an endodontic microscope, but not every clinic is equipped with an endodontic microscope. And that's where your CBCT can come to your rescue. So this, because this is again a root canal variation which is there. This is another case. Look at this picture. ये देखो यहाँ से कितना दिख रहा है तुम्हें? Single canal लग रहा है, ठीक है? And then just see the variation in the anatomy which is happening here. It is separating. It is again joining. It is separating. A very complex anatomy. So again, these are the cases which you feel on a conventional is easy, but when you open up the case, then you realize that you are dealing with a complex anatomy. And that's where your CBCT can come to your rescue. This is a periapical radiograph. This patient wanted to do a re-RCT of slower 7. So the dentist suggested that we better go for a CBCT. Now, as I was telling you, in CBCT we can see any structure with an unobstructed view. So this is what it happens. So if you click at a particular region, all this region of the same particular part would be exposed. So now in this region, we are just trying to locate the anatomy, how many canals are there, and in the axial window also. We can go from the top till the bottom, that we call from the coronal to the axial surface. Now if you see clearly, what I am highlighting is that you can see the mesiobuccal and your distal canal, but I cannot able to see the mesolingual canal in this. Only when I go down I am able to see the mesolingual canal. That means ऊपर का portion आपका calcified है, obliterated है. So again, this cannot be easily diagnosed on your conventional radiograph. On a CBCT, easily we can do it. See this picture. Now this you cannot do it on a conventional patient के ऊपर नहीं कर सकते, computer screen पे कर सकते हो. That's the advantage you get before just starting the case. So whenever you feel such complicated cases are there, it is always better to do for a CBCT. And this is the post-op with the master cone placed. All the 3 canals negotiated. Just see another case. Yeah. Now one more thing which is CBCT require, you require an apex locator, right? Why you require an apex locator? To find the working length, right? But with CBCT, as I said, we get a life-size images. So with just with a simple tool, I can determine the working length also on this. So very easy. So when we write a report for endodontic cases, we also give the working length of the tooth for the patient. So this helps the dentist precisely beforehand. He clearly knows what is the working length of the tooth, how many canals are there, and what can be the variations in those canals. The next case I am showing you is this case. Now as I told you, 5 times root canal was attempted. But what was the problem? The problem was, can you see one line here? When the dentist attempted the first attempt for root canal, his files just went from the main canal and there was a perforation which was created at that first sitting itself. So despite doing a proper root canal for the main, he was not able to identify that the perforation has already been happened. And that's the reason the patient was experiencing pain every time and he was just root canal filling the tooth. So these minute things, again, it's very difficult to diagnose on your conventional radiographs. It was only with CBCT that we were able to find or the variation in this thing. Another case, a case of perforation, and this is very common in endo because sometimes you do over preparation of the canal, or sometimes because of the deep caries also you get a pulpy floor exposure. So these things sometimes get missed. But in CBCT you can see a clear-cut case of perforation which can be seen here, which becomes difficult to diagnose on your conventional radiograph. Look here. The next thing is early diagnosis of periapical lesions. As I told you, conventional radiograph requires how much? 30% of bone loss before you can see it clinically or radiographically. But in CBCT, we don't require such thing. If the caries is there or if there is any periapical infection, immediately we can diagnose it. We don't have to wait for any changes to happen. Now what is this? A very large radiolucent structure here. What do you think this is? क्या रहेगा ये? ये इतना बड़ा. Commonest. This is a radicular cyst. It's a huge radicular cyst. Can you see this? With a thin bone. See this? And you can very clearly see which tooth are involved. There's a loss of the lamina dura and there's a cortical pit perforation. See this? ये दिख रहा है पूरा bone चले गया यहाँ से. So if you're trying to do a surgery for this, beforehand if you see a CBCT scan, you have a 3-dimensional picture beforehand itself. What type of structure is there? What structure I'm dealing with? What are the involved structures? If there is any bone left which is into it, and which is the bone which is in intact. So all these things can be detected earlier on, and so that's the advantage of CBCT. This is another case. The patient was having a pain in the mandibular right molar premolar region. So we are just using a CBCT, and in the CBCT we are just finding a periapical lesion. Can you see this? a round structure. See this. And can you see amount of the external root resorption which has happened? Very nicely you can detect this. Now all these things again, as I said, very difficult to diagnose on your conventional radiographs. Now there is an index which has been devised. This is just for academic purpose. So based on the size of the lesion, they have classified into various criteria, but this purely is for the academic purpose explained. Then comes for fractures. Now what is the problem with conventional radiograph? Conventional radiograph में अगर आपके patient को fracture है, even if it's a big huge jaw fracture, your X-ray beam has to pass tangentially to that fracture line. Only when your X-ray beam passes tangentially to the fracture line, you can see that fracture line on the radiograph. Patient में fracture रहेगा, but अगर आपका exposure proper नहीं रहा, तो fracture line दिखेगी नहीं. That happens in your conventional radiograph. But in your CBCT, no such thing. If there is a fracture line which is there, it would be clearly visible on your CBCT scan. So that's the advantage again your 3D technology has over a 2D technology. Now this is a root canal treated tooth here. Can you see this discontinuity here on the parietal root? That's your root fracture which is there. So this is a root fracture which is here. You can clearly see it here also. So that's the advantage of doing a CBCT scan. Another case, you have a maxillofacial trauma here. Can you see a thin line here? This is a young patient who had a history of fall. Again, these lines are at a microns level. So आपका IOP उसको detect नहीं कर पाएगा. Nor your periapical radiograph. It is just with your 80 micron scans which we are doing on a CBCT, you are able to detect these scans, these fractures. Now I am showing you this case, and this is a very interesting case we are getting nowadays in the clinic. This patient को dental caries नहीं है, but the patient is experiencing severe pain, and that's where the dentists are sending us to do a CBCT scan. And in a CBCT scan with the adjustment of the software, we are able to detect something as thin micro lines here. Can you see these lines? These are thin micro lines, and this is the cause of extreme pain to the patient. Clinically आप देखोगे crown अच्छा लग रहा है आपको, आप बोलेंगे इसमें dental caries नहीं, कुछ नहीं है. But at this micron level, you are able to detect these thin fracture lines, and this tells you that the patient gets a proper diagnosis from the radiological side that there is a microfractures. It is better you do the root canal for that patient. You do the root canal and immediately the patient is relieved of pain. So again, another indication when there is an unexplained pain, it is better to go for a CBCT, especially if you think it's of odontologic origin. This is another case. Can you see a thin line here? Root canal treated tooth, but a very very thin line. Again, this is a case of a fracture. As I said, in a root canal treated tooth, it is very very easy to detect the fracture lines. Another case. Can you see here? Again, a fracture in a root canal treated tooth. Again, if it is the radiograph is not taken properly on a conventional thing, IOPs or panoramic radiographs, you will not be able to detect this fracture line. But in CBCT, you can easily detect the fracture lines on the, even in the root canal treated tooth. Another picture I am showing you a fracture. See this, total separation of the tooth fragments. Now there are times for even in cases sometimes like this where I am not also getting confused with so much of the experience that whether this is a fracture line or whether this is an artifact which has been thrown by the GP material. This is a root canal treated tooth. The dentist has sent this patient to me to diagnose whether this patient is having a fracture or an artifact, or fracture in fact. And the GP material per se always throws this black lines. You can see these black lines like this. You take any scan having a root canal filling material, they throw such lines. So it sometimes becomes difficult for us whether this is a fracture case or this is just an artifact. So the simple trick we generally do is we always try to locate the pedal space. If the pedal space is breached at that particular point, it indicates that the patient is having a fracture. But if the pedal space is intact, it indicates that what we are seeing is actually just an artifact and it's not a fracture. But most of the time we are able to diagnose it properly and give a proper diagnosis to the dentist. The next indication is calcified canals. Look at these axial images. You can see a black shadow here, but not in this tooth. Why? Because it is completely calcified. So again, There is no use of doing any heroic attempts to do a root canal in this case because it's completely calcified. You just have to leave it. Coming to the next indications of pre-surgical assessment. Now, pre-surgical assessment matlab endodontic surgeries. If they want to do any endodontic surgeries, whether it's in the maxillary region or the posterior region, nowadays we have something called as the endodontic guides. You have guides for implants, but now we have guides even for endodontic surgery. Because why it is important? Because in the mandibular region, we have something called as the mandibular canal. Okay, so you cannot hamper or damage that mandibular canal. So to have a precision in that, you are supposed to diagnose or use your surgical guides. So this apicectomy guides, or which they called it, can be used with the help of CBCT. Now coming to the last part, and this is the recommendations given by the American Association of Endodontists along with the American Association of Maxillofacial Radiologists, is where should you use CBCT. As I said, we cannot advise CBCT for every cases, but there are some pinpoint indicators which way you should use it. First and foremost, whenever you feel there is an accessory canal, like a missed MB1 or MB1 canal or MB2 canal if you feel. Whenever you feel there is a variation in the root canal anatomy, that's when you should use your CBCT. You are having patient who is having pain, but he is not giving you any pinpoint signs. Again, that is an indication, better go for a CBCT scan. If there are some complications like instrument separation, instrument fracture, or you have a calcified canals or a dental trauma, again your best indications would be CBCT. In cases of resorptions, again it is better to do a CBCT because it will give you a more proper location of your resorption. Whether it's happening at a particular location, you can pinpoint tell it. This is the last slide, and this is a position paper which has been published in the Journal of Endodontics, in the International Endodontic Journal, and they have, if you just read it, a CBCT examination should only be considered after a detailed clinical examination, including your conventional radiographs. The potential benefits as well as risks should be identified. Means you have to take a call whether by advising CBCT, मुझे ज़्यादा information मिलने वाला है कि नहीं. If you feel yes, I can get more information, and generally it happens, then you go do for a CBCT scan. When you are advising CBCT for young children, always keep in mind that CBCT scan can cause radiation hazard. So you have to keep in mind and then advise CBCT for your child patients especially. But to learn is one of the most important thing for CBCT. अगर मैं आपको एक CBCT scan की DVD भी दे दूँ and you cannot able to open it, it's no use. आपके पास हमने films दे दिए CBCT के and you are not able to diagnose. Because whatever Dr. Jaju or any radiologist write, that does not mean it is a Brahma वाक्य. मतलब बोलते हैं कि वो वही सही ऐसा नहीं रहता है. Sometimes we are humans, we can also make mistakes. So it is necessary you also learn how to diagnose, how to read the CBCT images. Only then you can give a proper patient care to your patients. So that's what this thing is saying. All clinicians using CBCT must have an appropriate and accredited training. That's norms in today's time. Thank you very much for your patience hearing. If you have any questions, you can just email me at my email ID. Thank you. Any questions, you can free to ask me. भूख लगी है सबको. Once you start using CBCT, only then you will realize what are the problems. Because I think you are just right now. Once you start exposing yourself to CBCT, you start seeing the scans, then you realize what is the indications and where should you use it. Okay?
Thank you so much, sir, for such a comprehensive and enlightening session on CBCT. For the next lecture, I would like to invite Dr. Harsh Sharma, Director, State Forensic Science Laboratory from Madhya Pradesh.
Sagar University, PhD from Bhopal University, certificate courses Crime Scene Investigation from NICFS, MHA New Delhi, Diploma in Forensic Chemistry and Toxicology, NICFS, MHA New Delhi, certification courses on polygraph techniques for a period of 7 months, CFSL, CBI, New Delhi. In his vast experience of 38 years, he has inspected around 4,500 cases of various nature, homicide, arson, suicide, sexual assault, theft, etc. Having 100% efficiency in solving all the rape cases within a record time of 48 hours, where the accused culprits have been sentenced, minimum punishment of life imprisonment and maximum death penalty. Laboratory credentials: headed the only laboratory in Asia who have passed international US DNA efficiency test. In year 2018, only state in India, they have 18 convictions, that is death penalty in rape cases of Madhya Pradesh, for which state of MP got the Golden Book World Record by United States. He has been honored by State Chief Minister Shri Shivraj Singh Chauhan for the same. Honorable PM Shri Narendra Modi has also recognized the achievements by mentioning the same as an example during his speech in convocation of GFSU, Gandhinagar, Gujarat. Major accolades: awarded for Best Paper in Crime Scene Management in January 2009 at All India Forensic Science Conference at Ahmedabad. Awarded for the Best Paper of Crime Scene Investigation at All India Forensic Science Conference held at Jaipur. Meritorious Service awarded in Scene of Crime Management by MHA, Government of India, New Delhi. This was given by Shri Amit Shahji, the Home Minister of Gujarat. Indian Association of Medical Legal Experts has conferred him with the fellowship awarded for doing outstanding work in forensic science. International scientific visits: paper presented at International Association of Forensic Sciences at Tokyo, Japan. Third International Symposium on Advances in Legal Medicine at Osaka, Japan in 1996. 12th Scientific Meeting organized by International Epidemiological Association in 1990 at Los Angeles, California, USA. Attended 2 international seminars on advancing the scientific investigation of crime, UK in 1997. Presented paper and chaired a session in international conference at ARAB University for Security Sciences, Riyadh, Kingdom of Saudi Arabia in December 2018. Lecture delivered regular faculty at SPP National Police Academy, Hyderabad, and was examiner for IPS officers. Regular faculty in National Institute of Criminology and Forensic Science, Amateur Government of India, New Delhi. Delivered lectures at Northeast Police Academy, Meghalaya, many state police and judicial academies. He delivered talks in many central and state universities in India. Published many papers in national and international journals. He was member of International Society of Forensic Science in India, Society of Toxicology. He is Vice President of Indian Medical Legal Experts and Association. Sir, kindly come on the stage.
Thank you very much. First of all, I would like to thank the organizers for giving me this opportunity to talk to you regarding forensics. जनाब एक मेरा आपसे I'm telling to you, actually few of my cases they are sub judice, so please don't do recording. Recording that is not being done in my lecture. So please lights off. To begin with the forensic science, as I came to know are from the dental field, and few of my friends, they are from forensics. Regarding forensic science, I must tell you that forensic science is amalgam of various sciences. This includes established principles of physics, chemistry, botany, zoology, medical science, etc. So forensic science, it is amalgam of various sciences, and the established principles of science that is used in forensic science for the purpose of analysis. As you know, the science is always concrete. There is no if and but. If you throw a stone in the sky, that would fall, definitely. You do it n number of times, the same thing would happen. You go to any part of the earth and repeat the same thing. Every time the stone would fall. You do it n number of times. एक बार भी ऐसा नहीं होगा कि बीच में हवा में लटक जाए पत्थर। If at all हवा में लटकेगा तो फिर वो साइंस नहीं। I would be speaking in English and Hindi, as I'm just forgetting your name. Dick.
Yeah.
Dick sir was telling me, I couldn't listen his entire lecture in between I came, but I was really impressed with the guy. He was telling, to express anything, at times language that creates a problem. Number of thoughts are coming to your brain or mind, but you are not able to express because of the language problem, because you are not comfortable in Hindi or English, whatever. ऐसे 3, 4, 5 भाषाएं मुझे भी आती हैं, लेकिन भाषा जानना वो होता है जिसके इडियम में आप बात कर सको. Being from the central part of the India and mostly working with the police wala, so जो एक्सपोजर वाली ये बात कर रहे थे कि इंग्लिश पिक्चर देखिए, इंग्लिश अच्छे बोलने वालों के बीच में रहिए तो इंग्लिश आ जाएगी, आप इंग्लिश सीख जाओगे. तो मेरा एक्सपोजर जब कभी इंटरनेशनल कॉन्फ्रेंसेस में जैसे जापान गया, यूएस गया, यूके गया, वहाँ मजबूरी होती है. लेकिन यहाँ ये लिबर्टी है कि मैं अपनी भाषा में बात करूं जिसमें मैं सहज महसूस करता हूं. Of course, the technical terminology that would be in English. तो बाद में ये कह रहा था कि हर आदमी, हर बच्चा जब से होश संभालता है साइंस को एनकाउंटर करता है, चाहे वो स्कूल गया हो चाहे नहीं गया हो. पत्थर हवा में फेंकिए नीचे गिरता है, सूरज पूरब से उगता है पश्चिम को डूबता है. एवरीबॉडी जिसने साइंस पढ़ी है, he can always say because of the gravitational force the things are falling down, because the earth is rotating, इसलिए पूरब से उगता है पश्चिम को डूबता है. To be very, मैं बहुत सारी चीजें अभी इनके लेक्चर से सीखी. इन्होंने कहा कि कुछ अपने बारे में बात करें, तो भी शायद स्लाइड दिखाना और केसेस की बात करना या जो भी सब्जेक्ट है आप, वो शायद ऑडियंस को उतना अच्छा पकड़ के नहीं रखता. जो मैं समझा. To be very frank, I was never ever first class in my entire career. स्कूल डेज में तो जब पूरी क्लास पास तो अपन पास, तो 3-2 भी फेल हुए तो अपन पक्के में फेल हैं. रीजन वॉज दिस कि मेरे पास केवल पढ़ाई अकेली नहीं थी. आई वॉज डॉग लवर, आई वॉज अ रोज लवर, आई वॉज अ क्रिकेटर, आई प्लेड ईस्ट जोन, आई वॉज सेक्रेटरी ऑफ भोपाल कैनल क्लब, वन मेनी प्राइजेस इन रोज कॉम्पिटिशंस. तो केवल पढ़ना ही जो है मेरे लिए बहुत ज़्यादा जरूरी नहीं था. बट व्हेन आई केम टू दिस प्रोफेशन, because basically I was a man who was having passion. If at all I am having a dog, so my dog should win that dog show in which I am participating. I played with, in cricket I played with Mansoor Ali Khan Patodi, Mohinder Mannath, etc. Kassan Gowri. When I came to this field, then I was passionate to the subject, and any murder mystery, if at all that was there, मैं जब तक उसको सॉल्व नहीं करता था, मुझे रात में नींद भी नहीं आती, because of the passion. If at all you are having passion, as you are all budding doctors or scientists, if at all you are having passion, definitely you reach the height. अभी मेरे बारे में, मेरे साइटेशन में बहुत सारी बातें बताई हैं, तो शायद ये लोग नहीं भी बताने वाले थे, लेकिन मैंने इसलिए बोला कि पढ़ो, कि मैंने क्या क्या अचीव किया नेशनल लेवल पे, इंटरनेशनल लेवल पे. क्योंकि वो एक कहावत है ना, अब तो आजकल क्रुएल्टी टुवर्ड्स एनिमल के कारण सांप दिखाने वाले बीन नहीं बजाते हैं. पहले हम लोग जब छोटे थे तो वो पिटारी के अंदर सांप लेके आता था, खूब बीन बजाता था, खूब भीड़ इकट्ठी करता था, और जब भीड़ इकट्ठी हो जाती थी तो लोग ये सोचते थे कि इसके पास पता नहीं किंग कोबरा है, क्रेट है, वाइपर है, तो वो भले ही पनियल सांप निकाले, लेकिन बीन बहुत अच्छी होती थी. मैंने अभी इनसे कहा था कि बीन बजाओ पहले मेरे बारे में, और इसीलिए भी कि द पर्सन हु स्पीकिंग टू यू, कोई अथॉरिटी भी है कि नहीं कि ऐसे किसी को खड़ा कर दिया अनमोल में. So I suppose you know what is forensic science. It is amalgam of various sciences which is helpful to law. This includes established principles of physics, chemistry, botany, zoology, medical science, etc., etc. In forensic science, the word which comes, initially the judgment from honorable courts, they were delivering judgment on the basis of the human witnesses. जब इनिशियली मैं कोर्ट में जाता था तो मैं देखता था कि रेप केस में भी वही आदमी है, चोरी में भी वही है, मर्डर में भी वही है. तो मुझे समझ में आया कि प्रोफेशनल विटनेस होते हैं. क्योंकि जब भीड़ लगती है कि बाहर वारदात हो जाए, कोई केस हो जाए, सारे लोग देखने लगते हैं, गाड़ी खड़ी करके, स्कूटर खड़ा करके. लेकिन भीड़ को डिस्पर्स करने के लिए अगर पुलिस वाला कोशिश करता है तो होते नहीं है. फिर उनसे एक बात कहता है कि भैया 4 आदमी आके दस्तखत कर देना गवाही पे, तो भीड़ भाग जाती है. क्योंकि कोई इंटरेस्ट नहीं लेना चाहता अनटिल अनलेस उसका फैमिली का मैटर हो या फ्रेंड का मैटर हो. यहाँ पर स्टेपिंग किया फॉरेंसिक साइंस ने फिजिकल एविडेंस. फिजिकल एविडेंस, दे आर द फिजिकल एविडेंस जो होते हैं, एज द नेम सजेस्ट, हिंदी में बोलते हैं भौतिक साक्ष्य, इंग्लिश में बोलते हैं फिजिकल एविडेंस. अ थिंग विच इज फिजिकली प्रेजेंट, which has some shape, size. The physical evidence are coming in all the scene of crime, in all crimes. They are coming through a principle which was given by a French scientist. The name was E. Locard. He gave a theory that whenever there is a contact, there is a trace. जब दो चीजें एक दूसरे के संपर्क में आती हैं, पहली दूसरे के ऊपर, दूसरी पहले के ऊपर अपना कोई साक्ष्य छोड़ देती है. For example, I am touching this place. My fingerprints, they are on this surface, and the dust over this is within my fingers. In the same fashion, in rape cases, murder cases, accident, vehicular accident, एक गाड़ी का पेंट दूसरी गाड़ी पे, दूसरी गाड़ी का पेंट पहली गाड़ी पे, like this, the transfer of physical evidence that is there. One more thing, being a scientist, I must tell you that whatever has come to this earth is unique of its own. वो अपने आप में अनोखा है, उस जैसा कोई भी नहीं. In monozygotic twins, the mother and father are one. The DNA profile of both the childs, that is one. But यहाँ भी nature ने एक difference कर दिया. Fingerprints are not similar, they are different. And the entire forensic lab of India or of the world, they are just doing the comparison work. Whether this DNA profile matches with this DNA profile or not, whether this fingerprint matches with this fingerprint or not, etc., etc. I used to say a sheer in Urdu, almost in my all deliberations, इस जहाँ में ना किसी की नज़ीर ना मिसाल जो भी आया बेमिसाल. हर चीज़ अपने आप में अनोखी है और जैसा कोई भी. And we forensic scientists are taking advantage of this. Actually, in any case, proper recognition of the physical evidence is to reconstruct the event on the basis of the physical evidence. That is very, very important. In today's scenario, initially when I started my job of crime scene investigation, those days, a press note that was going to from the SP to the print media, because electronic media was not there. The same news was coming in almost all the newspapers with a change heading. But in today's scenario, as you know, at times police late पहुंचती है, मीडिया वाले पहले पहुंच जाते हैं, गोला बना के दिखाते हैं, ये देखिए खून पड़ा है, इसमें DNA हो जाएगा, इसमें NA हो जाएगा. एक आध बार तो मैंने बुला के पूछा है इनकर को, व्हाट इज द फुल फॉर्म ऑफ DNA और NA, या नार्को हो जाएगा. अरे सर हमको क्या पता. शाम को देयर इज a media trial. शाम को देयर इज a media trial, and in media trial, at times the retired person, they are delivering judgment also. So it is really, really bad. If at all the judgments which is going to the masses through the TV or media, if at all the judgment is different as it was narrated on the TV, then the public unrest is there. Here it's very, very important that the transparent examination of the scene of crime is to be done so that there should be no questions. Regarding birth, only 2 questions. A pregnant lady goes to the hospital, their relatives and the friends are waiting outside. The moment door opens, any nurse or doctor is coming out. The first question which is fired, baby boy or baby girl? The answer could be baby boy or baby girl. Immediately the second question is fired, whether the mother and child are okay or not. If the answer both are fine, no questions, over and done. If at all there is a death, death is of 2 types. one is natural and other is unnatural. In natural death, elderly person aging 85 years or 75 years going to the hospital with multiple complications, hypertension, cardiac problem, diabetes, etc., etc. In between, he or she was in the ICU, then came back to the normal ward. One fine day news comes, he or she is no more. Number of questions. How it happened? कल गया था तो चाय पी रहे थे, कोई बोलता अरे साहब मेरे सामने तो दलिया खाया, कोई बोलता अभी 10 मिनट पहले तो मेरी बात हुई थी, he was saying that he's fine. How he died? These are the questions. I am talking about the natural death. If at all the death is unnatural. You might have seen in Arushi case, every chai ke dukaan, pan ke dukaan, the people were discussing like anything. यारे फादर कैसे बेटी को मार सकता है, etc., etc. Here, the role of the forensic expert, that is very, very important. Now, coming to the actual cases, before I start with the actual cases, initially when I started my career, those days the founder director of the Medical Legal Institute, Professor Nilesh Chandra, he used to say, "Murda sach bolta hai, जिंदा आदमी झूठ बोलता है." It's true. जो जिंदा है उसके रिजर्वेशंस हैं, ये मेरा भाई है, ये मेरी बहन है, ये मेरा प्रेमी है, ये मेरी प्रेमिका है. But the person who is dead, उसका क्या रिजर्वेशन है? उसका कोई रिजर्वेशन नहीं. उसको जो बोलना है वो सच बोलेगा, लेकिन बोलेगा कि उसको जो उसके पास है. दूर खड़ा होकर अगर कोई पंचायतनामा बना रहा है पुलिस ऑफिसर, तो सोचेगा, अगर सोच तो सकता कि एक नीच वो जिसने मुझे मारा, उससे बड़ा नीच ये जो दूर खड़ा होकर मेरी तफ्तीश कर रहा है, इन्वेस्टिगेशन कर रहा है. Any murder mystery is just like a lock, and the key is lying at the scene of crime. होशियार आदमी वो है, वो चाबी उठा के ताला खोले. और ईश्वर की दया से, with the blessings of my parents and the passion I had, in my entire career, almost I have inspected 5,000 cases of various nature. Only 2 murder mysteries they were unsolved, otherwise all I detected. In rape cases, not a single case was there in which I could not detect even the punishment in any case, any suspect or the criminal which I pointed out was not got scot-free. The minimum punishment, that was life imprisonment, and the maximum, that was death sentence. Now, as I told you, कि मुर्दा सच बोलता है, जिंदा आदमी झूठ बोलता है. देखिए, समझ जो है वो पढ़ने से आती है और हकीकत देखने से आती है. देखते आप भी हो, देखता मैं भी हूँ, बस निगाह का फर्क है. और ये निगाह जब शार्पन हो जाती है, मैं ये नहीं कहता कि जितने भी केसेस मैंने सॉल्व किए जस्ट बिकॉज आई हैड प्लेंटी ऑफ क्वालिफिकेशन, प्लेंटी ऑफ एक्सपोजर. मुझे लगता है कि इन माय ओपिनियन साइंस इज नथिंग बट इट इज ऑर्गेनाइज्ड कॉमन सेंस, एंड अनफॉर्चुनेटली इट इज नॉट कॉमन इन कॉमन मैन. इफ यू यूज योर कॉमन सेंस एनीवेयर, you would succeed. This is my personal opinion. Because as I told you, I was never ever a first class student. The maximum percentage I could get in MSc final, that was 58%. So again, second class. Otherwise throughout third class. देखिए मुर्दा कैसे बोलता है. If a dead body is lying on the floor in the pool of blood, मैं उसके पास जाऊंगा, उसका हाथ पकड़ के ऐसे करूंगा तो कर्रा हो गया, स्टिफ हो गया। मुर्दा कह रहा 6 से 8 घंटे हो गए मुझे मरे हुए, बिकॉज राइगर मोर्टिस सेट हो गया। सामने देखता हूँ कोई स्टैब इंजरीज नहीं है, कोई इंजरी नहीं है। पलटा के देखता हूँ तो पीठ के ऊपर 6-7 स्टैब इंजरीज हैं। और बारीकी से देखता हूँ शर्ट पे, बिकॉज द क्लॉथ्स दे आर द फर्स्ट कवरिंग ऑफ द बॉडी, फर्स्ट थिंग ऑफ द बॉडी। तो देखता हूँ कि एक एंड जो है उसका शार्प है, दूसरा ब्लंट है, तो दूसरा जो नाइफ है उसका दोनों एजेस शार्प है। दैट मीन्स 2 knife they were used by 2 different person। ये कौन बता रहा है मुर्दा कि देखो साहब पीछे से मारा, 6 से 8 घंटे पहले मारा, उसके जूतों में खून भरा है। तो मुर्दा कह रहा है कि चाकू लगने के बाद एकदम नहीं गिर गया था मैं, अगर एकदम गिर गया होता तो जूतों में खून नहीं भरता। ब्लड हैज ट्रिकल्ड डाउन बिकॉज ऑफ द ग्रेविटेशनल फोर्स। Who's telling me? Dead body। जिस तरीके से मुर्दा सच बोलता है, इसी खून बोलता है। और खून कैसे बोलता है मैं बताता हूं। उससे पहले बड़ा अच्छा सा केस बताता हूं, जो मैंने बोला कि साइंस इज नथिंग बट इट इज ऑर्गेनाइज्ड कॉमन सेंस। भोपाल में भी सबसे अच्छी जो लोकेलिटी है दैट इज अडारा कॉलोनी, सबसे कॉस्टलीस्ट एरिया है, रेसिडेंशियल एरिया। वहाँ भी सेक्टर्स में है, E1 सेक्टर जो है वो सबसे ज़्यादा महंगा है। वहाँ पर 5-5 हज़ार स्क्वायर फीट में कोठियाँ हैं लोगों की। आज से 20-25 साल पहले देयर वाज अ कॉल फ्रॉम डेनिस पी, ही रिटायर्ड एज डीजी ऑफ मध्य प्रदेश। ही कॉल के डॉक्टर साहब यहाँ 2-3 लाख की चोरी हुई है, और टेप रिकॉर्डर गए हैं, कंप्यूटर्स गए हैं। कंप्यूटर उस समय एसेट्स में माना जाता था, इनके पास बंगला है, गाड़ी है। एंड द कंप्लेनेंट वाज सन ऑफ वाइस चांसलर, then वाइस चांसलर ऑफ लखनऊ यूनिवर्सिटी। He asked me to inspect the scene of crime. I said, sir, you know I am not going in the theft cases. Of course I know you are going in the body offenses, but last year भी इनके यहाँ चोरी थी, आप जाके देखा। नहीं ठीक है, मैं गया तो बहुत भीड़ भाड़ थी। चोरों ने जो एंट्री और एग्जिट था वो एक ही डोर से किया था। उस दरवाजे के ऊपर एक लॉक लगा था। वो लॉक को हैक्सॉ से, आयरन कटिंग हैक्सॉ से उसने काट के एंट्री किया था और चोरी किया था। द लॉक वाज लाइंग ऑन द फ्लोर। इसको देख के मैं थोड़ा सा, बाकी मेरे साथ और भी थे, फिंगरप्रिंट एक्सपर्ट थे, पुलिस डॉग था, तो मैं आके गाड़ी में बैठ गया। एवरीबडी सेड देन ACP said कि डॉक्टर साहब यू आर नॉट इंटरेस्टेड इन थेफ्ट केसेस। हालांकि बड़ी चोरी आज से 20-25 साल पहले 2-3 लाख की चोरी, कंप्यूटर वगैरह सब महंगा काम था। आज भी बहुत छोटी रकम तो नहीं है 3 लाख रुपए। 20 साल पहले तो आप समझ लीजिए कितनी बड़ी होगी। जब भीड़ थी इसलिए मैं कुछ बोला नहीं। बाद में वो अगेन देन ACP ही आस्क्ड मी कि सर आप देख नहीं रहे। ऐसे तो इट इज नॉट रिक्वायर्ड। एनी वन ऑफ यू जिसने मेरा पहले लेक्चर नहीं सुना है वो हाथ खड़ा करके बताएं कि मैंने क्यों मना कर दिया देखने से। This is the same photograph which was taken at the scene of crime. Anyone? नहीं। देखिए मैंने कहा ना कि साइंस इज नथिंग बट इट इज ऑर्गेनाइज्ड कॉमन सेंस, एंड अनफॉर्चुनेटली इट इज अनकॉमन एंड कॉमन। ये देखिए अगर तो ताला ये खुला हुआ है, अगर ये लगा हुआ ताला होता तो ये पीस इसके स्लॉट में होना चाहिए था विद इन द लीवर्स। तो खुला था ताला तो काटेगा क्यों कोई? इसमें क्या देखना था? इट वॉज अ फेक चोरी। अगर लगा हुआ ताला होता तो ये पोर्शन उसके अंदर कौन सा काम कर रहा है भैया, ये स्लॉट में होना चाहिए था, ठीक है। और ये ट्रांसफर्स कटिंग, अगर लगा हुआ ताला कटता तो कटता तिरछा, ऑब्लिक। अगर ऐसा होता ये पीस इसमें फंसा हुआ होता तो मैं जमीन के ऊपर जहाँ पर ये ताला लगा था मैग्नेट को घुमाता तो आयरन डस्ट उस पर चिपक जाती, इससे ये बात इंश्योर हो जाती कि ये ताला यहीं पे था। लेकिन इसमें तो कुछ करने की जरूरत ही नहीं थी, क्योंकि ये ताला तो खुला हुआ काटा है, किसी टेबल टॉप के ऊपर रख के हेक्सा से काट दिया। अब इसमें कौन सी क्वालिफिकेशन की जरूरत है या कौन सी इंटेलिजेंसी की जरूरत है? सिंपल ऑब्जर्वेशन। Actually, what we are doing after seeing the scene of crime, we are reconstructing the event on the basis of the physical evidence found at the scene of crime. In this particular, this was the evidence. बाद में पता चला कि इनका जो बहनोई था इंश्योरेंस कंपनी में सर्वेयर था। Every year he was lodging a fake FIR and minting money like anything. He was also शर्मा, जब कभी शादी वादी में मिल जाते तो अपनी बीवी का हाथ पकड़ के बाहर में रखता था मुझे। क्योंकि टाइम नहीं है इसलिए मैं कुछ केसेस छोड़ देता हूँ। ये लाइट प्लीज बंद करवा दीजिए। लाइट नहीं है, बंद नहीं होती। अच्छा कोई बात। यार ये देख रहे हैं क्या हो गया? जैसे मैंने कहा जिंदा आदमी झूठ बोलता है, ऐसे ही खून बोलता है, बशर्ते कि खून की भाषा पढ़नी आती है। खून को का लैंग्वेज पढ़ना मैं एक केस के बाद में सीखा या शुरू किया। इन अ पर्टिकुलर केस दैट वाज अ केस रजिस्टर्ड अंडर एक्सीडेंट एक्ट। एक ट्रक वाले ने स्कूटर वाले को मार दिया। जब मैंने क्राइम सीन देखा, आई वाज वेरी श्योर दैट इट इज अ डेलिबरेट किलिंग and I wrote my report like that, and on the basis the case was registered under 302. जब उसका ट्रायल हुआ तो काफ़ी बड़ा आदमी था, उसने काफ़ी डिफेंस काउंसिल बड़े बड़े खड़े किए। उसमें एक ने मुझे ह्यूमिलेट करने के लिए कहा, डॉक्टर साहब आपने ब्लड देखा? ऐसे भी देखा। बोला आपने देखा, रास्ते चलते आदमी ने देखा, स्वीपर ने देखा, उसमें क्या फ़र्क है? मैंने सेट की नहीं, केमिकली हमने टेस्ट किया था। बोला नहीं, वैसे देखने में तो एक सही दिखता है। देन आई थॉट कि अब खून बोलता है, ये बात देखनी। तो ब्लड स्पीक्स इन वॉल्यूम। इफ एट ऑल you see this type of blood stains at the scene of crime, it is suggestive that it's a blood fallen from height. आप चाय पीते हो, एक बूंद चाय की गिरती है, इसी तरीके का पैटर्न बनता है और किसी तरीके से इस तरीके का ब्लड का पैटर्न नहीं बनेगा। दिस इज कॉल्ड वीनस हैमरेज। वेन्स दे आर सुपरफिशियली सीटेड। जो डॉक्टर अपने ब्लड का सैंपल लेता है एक्सेट्रा एक्सेट्रा, तो वो वेन के अंदर जो हरी हरी दिखती रहती है, इसका डाया पतला होता है और हार्ट का काम है ब्लड को पंप करना। जब प्रेशर से पंप करता है और वेन कटती है तो ब्लड की स्टिक्स दिखाई देती हैं एनी सीन ऑफ क्राइम पर। दैट इज सजेस्टिव दैट इट इज अ ब्लड which has come out from the veins. So this is venous hemorrhage and this is arterial hemorrhage. Arteries, they are deeply seated and the dia of the arteries that is wider. The work of the heart is just to pump the blood in different organs. जो लोग बोलते हैं ना, दिल पे मत लेना, ये दिल का बहुत अच्छा आदमी है, heartiest congratulation, it is all rubbish. Heart has nothing to do with the thoughts. Everything, whatever you do, it is governed by the brain, not by the heart. Even the heartbeat at times, if we are seeing some horror movie or something like that, your heartbeat that would change. So this is arterial hemorrhage. फॉर एग्जाम्पल एक सिरिंज में पानी भरिए, नीडल लगा के प्रेशर से करिए, रिलीज करिए, तो पतली धार जो होती है दैट इज वीनस हैमरेज। नीडल निकाल के प्रेशर से फेंकिए तो इट इज आर्टियल हैमरेज। एंड इफ एट ऑल देयर इज नो डेफिनेट पैटर्न देन इट इज कॉल्ड स्मज टाइप ऑफ ब्लड। Now how the blood speaks in volume, I will show you a particular case. This was a case in which महर्षि करके एक एजुकेशन सेंटर है भोपाल के आउटस्कर्ट्स में। इसके इंडिया में बहुत सारी ब्रांचेज है, दिस इज इन एकर्स, बल्कि अब्रॉड भी इसकी ब्रांच। यहाँ पर जो अकाउंटेंट थे उनका डेड बॉडी हॉस्टल के अकोमोडेशन में रहते थे ये, इनका डेड बॉडी मिला। द स्टोरी वाज लाइक दिस कि दिस पर्सन was sitting on this cot जब मेड स्वीप करने के लिए आई कमरे को, तो ये कमरे के उसमें पलंग के ऊपर बैठे हुए कुछ पेपर वर्क कर रहे थे, क्योंकि बाहर से ऑडिट टीम आई हुई थी। मेड ने स्वीप किया, स्वीप करने के बाद जाते समय शी आस्क्ड, सर आर यू कमिंग टू द कैंटीन फॉर द ब्रेकफास्ट और शुड आई सेंड समवन टू योर रूम along with the breakfast? He said, I will be coming to the canteen. जब ये 11 साढ़े 11 बजे तक नहीं आए तो किसी को भेजा, तो देखते हैं कि पूल ऑफ ब्लड में इनकी बॉडी पड़ी। इनको जब पलटा के बिठा गया तो इनका गर्दन कटा हुआ, फ्रंटल एरिया ऑफ द नेक इट वाज स्लिट। तो हल्ला हो गया कि इनका अकाउंटेंट साहब का मर्डर हो गया। आई वॉज कॉल्ड टू इंस्पेक्ट द सीन ऑफ क्राइम। तो मुझे जो क्रिटिकली चीज देखनी थी, मैंने कहा ना देखते आप भी और देखता मैं भी। इसके फर्श के ऊपर कोई खून की बूंद आपको नहीं दिखेगी। इस पर कोटा स्टोन लगा हुआ था, इट वॉज गिविंग जस्ट अ मिरर लुक इम्प्रेशन। कितना बढ़िया पोछा लगाया गई थी वो, मिरर लुक इम्प्रेशन था, कोई ब्लड स्टेन नहीं था। कोई भी चीज, द आर्टिकल्स केप्ट इन द रूम दे वर नॉट डिस्टर्ब। देखिए पलंग अपनी पोजीशन के ऊपर है, अलमारी अपनी पोजीशन पे है, बल्कि हल्का वो जो एक एल्यूमिनियम का स्टैंड है कपड़े सुखाने का, वो भी अपनी जगह पे। सो इट वाज सजेस्टिव दैट यहाँ पर कोई झगड़ा वगड़ा नहीं हुआ है। दूसरा, कोई ब्लड स्टेन फ्लोर के ऊपर नहीं है अदर देन द पूल ऑफ ब्लड। एंड द बैक साइड ऑफ द शर्ट एंड द ट्राउजर्स दे आर नॉट हैविंग एनी ब्लड स्टेन्स, एनी इंजरी मार्क। इसको और क्रिटिकली देखा तो ये डेस्क, दो डेस्क को मिला के इसने अपना ड्रेसिंग टेबल बनाया हुआ। इस ड्रेसिंग टेबल के ऊपर एक सेंटर में मिरर है, मिरर के ऊपर देयर इज अ स्पर्टिंग ऑफ ब्लड। दूसरा, ब्लड दो तरीके का होता है, एक होता है एंटीमॉर्टम ब्लड, एक होता है पोस्टमॉर्टम ब्लड। एंटीमॉर्टम ब्लड मीन्स व्हेन द पर्सन इज अलाइव, देन द क्लॉटिंग प्रॉपर्टी ऑफ द ब्लड दैट इज देयर। Technically, or for doctors, everybody might be knowing, because of the enzyme, pharmacogen enzyme is there in the blood, which is responsible for the clotting of the blood. When the person dies, then this clotting property vanishes. फिर हमारे यहाँ देहाती भाषा में कहते हैं कि अरे वो मर गया, उसका तो खून पानी हो गया, because the clotting property that is not there. If you see the blood on the tabletop, that is clotted blood. That means it is antemortem blood. And the spurting of the blood on the mirror, that is suggestive. When the person was standing in front of the mirror, the neck was cut. This is the reconstruction on the basis of the physical evidence found at the scene of crime. When more critically, when I examined the tabletop, ये उसका अपना शेविंग बॉक्स था जो खुला हुआ था, and just near the watch, if you see, there is a wrapper of the blade, double-edged blade. When I opened this wrapper, the glue was sticking to my fingers and the blade was missing from the wrapper. So I thought it was recently opened. If at all पुराना खुला हुआ होता तो इसका glue जो है सूख गया होता. Now you see the spurting of blood, that is more towards the left side. Is it clear to you? Pressure के साथ में blood left side में फिरता है, not on the right side. You see the slit marks within the pool of blood, and both the soles, they are smudged with the blood. After seeing all this, I said to the media, to the relative of the deceased, to the police, in my opinion, it is a case of suicide, not homicide. कोई बात मेरी मानता नहीं. मैंने कहा in advance, I am telling you few things. ऐसा मिल जाए तो मान लेना. बोले सर बताइए. मैंने कहा एक तो ये आदमी राइट हैंडर होना चाहिए. रीजन बीइंग इसने ब्लेड निकाला, राइट हैंड में लिया, लेफ्ट साइड से अपनी गर्दन को स्लिट करना शुरू किया शीशे में देख के. तो जो मेन आर्टरीज थी लेफ्ट साइड की कटी. हार्ट का काम है ब्लड को पंप करना, प्रेशर के साथ में ब्लड पिका लेफ्ट साइड, इसलिए इसको राइट हैंडर होना चाहिए. नंबर 1. नंबर 2, इसका जो नेक कटिंग होगा लेफ्ट साइड में, वहां पर हेजिटेशन मार्क होगा. हेजिटेशन मार्क समझते हैं आप? नहीं समझते. खासतौर से यंगस्टर्स जो आप लोग के एज ग्रुप के हैं, प्रेम व्रेम के चक्कर में कि नस काट लूंगी या नस काट लूंगा और खून से लिख लूंगा एक्सेट्रा एक्सेट्रा, फिर अटेम्प्ट करते हैं, फिर डर लगता है, दर्द होता है, हाथ हटा लेते हैं, फिर मन बनाते हैं नहीं करना ही है, फिर काटते हैं. तो उस तरीके के जो वुंड होते हैं, दे आर कॉल्ड हेजिटेशन वुंड्स, बिकॉज दे आर सेल्फ इन्फ्लिक्टेड वुंड्स. तो इसने दाएं हाथ में ब्लेड ली, बाएं तरफ से काटा होगा, जब दर्द हुआ होगा तो फिर हटाया होगा, फिर लगाया होगा. तो ये देखने को मिलेगा. नंबर 1. नंबर 2, इसकी जो नेक का कटिंग का जो स्किन है, वो दैट वोंट बी इन अ स्ट्रेट लाइन, दैट वुड बी इन बिट्स एंड पीसेस. क्योंकि दूसरा आदमी जब किसी का गला काटता है तो फिर गले ही काट रहा है, उसे क्या सोचना है, हटाना है और लगाना है. दूसरी चीज. तीसरी चीज, इसके दाहिने हथेली के नीचे ब्लेड मिलना चाहिए. ये होगा तो मानोगे कि नहीं. और टेक्निकली जो आदमी समझना चाहता है, इन माय ओपिनियन दिस मैन वाज स्टैंडिंग इन फ्रंट ऑफ द मिरर. ही टुक अ ब्लेड, लेजर बैंड ब्लेड फ्रॉम द रैपर, राइट हैंड से लेफ्ट साइड में अपने को शीशे में लेके गला काटा. और जब ब्लड एक आदमी के शरीर में तकरीबन 5-5.5 लीटर ब्लड होता है, जब ब्लड की सप्लाई ब्रेन को कम हुई, as you are standing in the pool of blood, ये जो है फिसल के गिर पड़ा अपने खून में. इसको अगर कोई और मारता तो ये खून में क्यों खड़ा रहता है? पहले तो इसका फॉल जो है दैट इज वेंट्रली, पेट के बल गिरा. कोई दूसरा पीछे से आके गर्दन में इसका चाकू मारता, काटता गला, तो इसका फॉल होना चाहिए था डॉर्सली. क्योंकि अपने को कोई आगे से पीछे धक्का दे तो अपन गिर पड़ोगे एकदम से, बिकॉज सेंटर ऑफ ग्रेविटी इज डिस्टर्ब. If at all anybody is pushing you from the back side, you can balance with the hands. So all things are suggestive that it is a case of suicide, not homicide. Now, you see, गीले cotton swab से जब साफ किया गर्दन, you can see that is the cutting is not in a straight line, and you can see the hesitation mark on the left side, and इसके right hand को जब wet cotton swab से साफ किया, you can see a sharp cut on the right thumb when we were school going guys, those days ये ट्विन ब्लेड तो आते नहीं थे, ये डबल एज ब्लेड होते थे. फादर की जो ब्लेड यूज होती थी उससे पेंसिल शार्पन करते थे तो ऐसे कट बन जाते थे शार्प. एंड लास्ट बट नॉट द लीस्ट, जो राइट पाम के नीचे क्लॉटेड ब्लड था, जैसे मलाई हटाते हैं ऐसी ब्लड के क्लॉट को हटाया. You can see the laser brand blade which was lying below the right palm. The autopsy was done by then Director Medical Legal Institute, Dr. T.K. Satpathy. He was also likely to come here, but because of some reason he is not here. So he did the autopsy examination and he was also of this opinion that it was a case of suicide, not homicide. If at all this type of investigation was not done at the scene of crime, ऐसी कटी हुई लाश को अगर डॉक्टर के पास ऑटोप्सी के लिए जाती, he would have definitely opined that it is a case of homicide. पुलिस फिर पता नहीं किसको पेश करती, क्या होता. Like this, the case was solved. I got the first prize in All India Forensic Science Conference to present this case, and this case was published in one international journal also. This is again a case of unusual suicide. During the Diwali festival, a person kept a sutli rum in the buccal cavity and ignited it, and you can see the repercussions. These are the splinters, mandible along with the tooth. You can see. Over the matchstick. Now directly coming to the rape cases with the minors. I must tell you, in my entire career, not a single case I have seen in which the outsider was involved. Mostly the relative, the neighbors or something like that. In this particular case, that time, the DNA facility that was not there. In this particular case, a girl aging 6 years was missing in the evening time. tooth. She was strangulated from her own salwar. These are called tattoo spots, which is suggestive of a stricture depth. Yeah, red big. You can see abrasions on the neck, bruise, abrasions, contusions on the back side. As a person having a weight of almost 70 kilograms, he mounted on the girl on this rough surface. ये जब उसके घर से चप्पल जूते आए, you can see the algae present on the sole of the chappal, marked with the arrow. The trousers, they were smudged with the mud. This was the underwear, this was the shirt. This is the actual photograph of the rear slide of the victim. You can see actual sperm. This is the head, this is tail. This is the head, this is tail, this is the head, this is tail. And there is a spermatova on the underwear of the accused. ये कॉटन स्वैब जो है उसके चेहरे से लिया था, उसमें you can see बच्ची के, you can see the algae, and this was the soil of the area. The algae is there. The algae was propagated in the lab. Same algae. Diatoms, as it was a rainy season, diatoms were there, and diatoms were also found on the accused trousers and sole of the slippers or chappal. As the DNA technique that was not there, so on the basis of this physical evidence, the death sentence it was awarded to the suspect or the neighbor of the deceased. This is the case I was narrating during the inaugural speech. A girl aging 14 years, she was raped and murdered, and it was a very, very sensational case. Then DGP and then Chief Minister of Madhya Pradesh, Mr. Digvijay Singh, was at the scene of crime. And within a couple of hours, we were able to solve this murder case. And in this particular case, I haven't heard the name of forensic odontology. So they were in excitement. The suspect ने उसके शायद लेफ्ट साइड पे there were bite marks. What we could do, एक आलू लिया, उसके ऊपर वो सस्पेक्ट के दांत लगवाए, फिर वो दांतों का जो बच्ची के चेहरे के ऊपर, चीक्स के ऊपर बाइट मार्क्स थे, उससे मैच किया, एंड और भी सर्कमस्टेंशियल एविडेंसेस थे. सो वेरी ओल्ड केस एंड लाइफ इम्प्रिजमेंट दैट वाज गिवन द गाय. It's a very sensational case. In this particular case, and this case I solved on the monitor of your computers. At that time I was doing the analysis of the narcotic material, and I had seen the crime scene. It was so sensational that next day the Bhopal Bandh was declared by the opposition parties, and the dead body was kept on the CM house. The girl was raped and she was murdered. So gala kaat diya tha. After seeing the cutting area on the monitor, when I was doing that, I was very sure in this particular case, the cutting weapon that should be sharp, not very sharp, and light in weight. Then all senior police officers asked me, what should be that weapon? पता नहीं, शायद उस बच्ची को इंसाफ मिलना होगा, मेरे मुंह से निकल गया कन्नी समझते हैं जो मेसन प्लास्टिंग करता है जैसे. That is light in weight, sharp but not very sharp like knife. उसको अगर ब्रेक का इतना पीस काटना है तो उसे मल्टीपल स्ट्रोकिंग से वो उतना पीस काट लेता है. जैसे ही ब्रेक का मैंने नाम लिया, वो कन्नी का नाम लिया, सारे के सारे उछक गए, बोले ऐसा सस्पेक्ट है हमारे पास. Then we took the penile swab and DNA was done, and in fast track 9 working days the death sentence that was awarded. because of the time constraint, this case I presented in Japan. It's a case of Italsi Dehat. बस एक छोटा 2 केस बताता हूँ, इसके बाद में बंद करता हूँ. Bhopal is famous for city of lakes. In small lake, a bag was in a bag, 1 head, 2 hands, and 2 leg cut pieces. They were found. Rest of the trunk that was missing. The marka on the bag, that was bronchio. Being from the family of doctors, I was having a thought that in this particular case, some doctor or MR should be involved. Reason being, that which is available or sold in the market are having other markers like Adidas, Nike, etc., etc. Bronchio is a term which is related with the lungs. Bronchus, bronchi. So, I was having a thought that it should belong to a medical practitioner or a medical representative. This, you can see, this is the 2 hands and 2 legs. And the cutting, that was suggestive as the bone marrow was very, very apparent. So I was having this thought, in this particular case, the weapon for cutting must be a slaughter's knife because it is heavy and very sharp. Otherwise, you can't cut a bone from a normal knife. The problem was to identify the deceased, as the long hairs they were in the back and multiple earrings they were in the earlobe. अभी कुछ साल पहले फैशन चला था ये लड़कियां कान में बहुत सारी बाली पहनती, अब आजकल शायद सॉफ्ट. तो ये था कि ये किसी औरत की है, लड़की है. This was the first stage. This was the second stage. This was the third stage. This was the fourth stage. मैं मैडम मारिया को बताना चाह रहा था कि स्पेशली आपका मैंने भी लेक्चर जब सुना, फेशियल मतलब हाउ टू ब्यूटीफाई, ज़्यादा एज के बाद में रिंकल्स को ठीक करना, डबल चिन को ठीक करना, एक्सेट्रा एक्सेट्रा. इन दिस पर्टिकुलर केस, दिस वॉज द इनिशियल स्टेज. कॉटन के स्वैप बना के अंदर से डाले, आंखों को पीछे से धक्का दिया, बाल सर पे जमाए. तो ये सब करने के बाद में फर्स्ट टू फोर्थ जितना आसान दिख रहा है उतना होता नहीं है. सड़ी हुई डेड बॉडी के साथ में काम करना, इट रिक्वायर्स अ पैशन. Ultimately, this was reconstructed, this face was reconstructed and circulated in the newspapers. यहाँ पर पता चला कि ये लड़की सीआई कॉलोनी जहांगीराबाद करके एक जगह है, वहाँ पर एक मुस्लिम लड़के के साथ रहती थी. तो ये लड़का जो है, इसका फादर डॉक्टर था, सलामतपुर करके जगह है भोपाल के पास में. जब पुलिस ने वहाँ से उसको पकड़ा तो कहानी ये निकल के आई, उसका फादर डॉक्टर था, कहानी ये निकल के आई कि ये लड़की शी वॉज फ्रॉम माउंट आबू राजस्थान एंड शी वॉज इन लिव इन रिलेशन विद द गाय. इसके फादर ने भोपाल मेडिकल कॉलेज में पढ़ने वाली एक लड़की के साथ में उसका इंगेजमेंट कर दिया. सो ही वॉज एक्साइटेड लाइक एनीथिंग. तो ये लड़की से बोला कि तुम जाओ. शी सेड व्हाट नॉनसेंस यू आर टॉकिंग, आई एम हियर विथ यू सिंस लास्ट 2-3 years. अपने हस्बैंड को, बच्चे को छोड़ के वहाँ आई हूँ. नाउ वन फाइन डे यू आर टेलिंग मी टू गो आउट. इट इज नॉट डन. व्हाट ही डिड व्हेन शी वाज स्लीपिंग, एक बड़ा पत्थर लाया, इसके सर पे मारा. बिकॉज ऑन द स्किल the fractures that was very very evident. हार्ड एंड ब्लंट ऑब्जेक्ट से किसी से मारा है, ये बात पता था. तो इसके जो मैं हमने कहा था कि weapon of cutting जो है that should be slaughter's knife. You can see this is bone marrow because the slaughter's knife is very sharp and heavy. वो लकड़ी के गट्ठे के ऊपर रख के और काटता है. So this way only it is possible. तो पता ये चला कि ये इसने लड़के ने जहाँ से मीट लाता था उससे कसाई से इसने बूचर से जो है नाइफ बोरो किया था, उससे उसने हाथ पर काटे, सर काटा, बैग में भर के और तालाब में डाल दिया। रेस्ट ऑफ द ट्रंक ही ट्रांसपोर्टेड इन अ बैरल, बिग बैरल, और ठेले पे ले गया बस स्टैंड, नागरा बस स्टैंड, वहाँ पर बस पे चढ़ाया। द पीपल वर सेइंग इट इज फाउल स्मेलिंग, ही सेड नथिंग, फिश इज देयर। और ऐसा करके उसने ट्रांसपोर्ट किया और सलामतपुर के आगे किसी अंडर ब्रिज के नीचे वो भी उसने छोड़ दिया, वो भी रिकवर हो गया था। इसने जब नाले में पत्थर फेंका था उस पत्थर को हमने निकलवाया। Apparently there was no blood, but the chemical test which we are performing, it is sensitive in ppm level, that is in parts per million level. So the blood was there and the bone pieces on the floor of the room. You can see उस समय डीएनए चालू हो गया था तो सब डीएनए किया and life imprisonment that was given to the guy. Regarding hanging cases, I will show you a small bite because if at all I am speaking on hanging, then what is partial hanging, what is complete hanging, what is judicial hanging, it is difficult to cover. So I will be showing a small bite on hanging cases. You can see in your YouTube. Another case of partial hanging. इसमें भी लोग डाउट कर रहे थे कि इट इज अ केस ऑफ होमिसाइड। नूतन कॉलेज भोपाल में सबसे फेमस कॉलेज है, उसकी प्रिंसिपल की बहू है ये। ऑल पार्शियल हैंगिंग केसेस।
सुशांत सिंह was a partial hanging?
देखिए हैंगिंग के केसेस में एंटीमॉर्टम हैंगिंग है, पोस्टमार्टम हैंगिंग है, हम बड़ी आसानी से पकड़ लेते हैं। पहले इनिशियली व्हेन आई स्टार्टेड माय करियर, दोस डेज आई वाज ऑलमोस्ट टेकिंग 2.5 hours to inspect a scene of crime. ग्रेजुअली टाइम कम होता गया। आज की तारीख में 5 मिनट में बाहर आके बता देता हूँ, मार के टांगा है कि खुद टांगा। बिकॉज I told him, initially the pressure was there, but I'm very aware of the thing, how to say no to the people. There are ways to say no to the people. अभी आपकी क्लास में मैंने बहुत सारी चीज़ें, जैसे वो डॉग का एग्जाम्पल लिया आपने, तो आपने कहा मेलोडी में नहीं बोला क्या, तो कोई चीज़ को थोड़ा तरीके से बोला जाए, मैसेज चला जाए सामने वाले के पास, there is a strict no, but the ways are number of ways to say. So I conveyed the message to the persons जिनसे कभी प्रेशर माउंट हुआ, तो लोगों की एक बार समझ में आ गया, फिर कोई नहीं बोला. तो लास्टली मैं ये बताना चाह रहा हूँ, आई एम नॉट प्रेजिंग माई सेल्फ, आई एम जस्ट टेलिंग यू वन इंसिडेंस. भोपाल में, यू माइट बी नोइंग, देयर वाज अ मास gas disaster. Thousands of people died because of the methyl isocyanate leakage. It was the biggest tragedy in the world. Few years back, there was a leakage in the chlorine tank of a swimming pool. So I was called by the control room late night. They asked me to come. And what I am going to do there? बोले सर वो तो आप चले जाओ साहब, पूरा सेकंड स्टॉप पे प्रकाश स्विमिंग पूल में ये लीकेज हुआ है, लोग भाग रहे हैं घर छोड़ छोड़ के, बिकॉज ऑफ दी MIC का जो पुराना एक्सपीरियंस है गैस लीकेज का, लोग बहुत ज़्यादा हॉरिफाइड हैं. जब मैं गया तो टैंक में लीकेज हो रहा था, खूब भीड़ भाग रही थी, फायर ब्रिगेड आ गया था. मैंने कहा भाई क्लोरीन का लीकेज हो रहा है तो सबसे बढ़िया तरीका होता है तो उसको पानी में डाल दो, पूल में डाल दो, तो गैस बाहर नहीं. बोले सर विंटर्स का टाइम है, पूल तो खाली है और सिलेंडर्स भी बड़े बड़े थे, एक सिलेंडर उसमें से लीक कर रहा था, तो एक आदमी से उठ नहीं सकता. एंड वी आर हैविंग ओनली वन मास्क, गैस मास्क. बिकॉज आई हैड एनकाउंटर्ड भोपाल गैस ट्रेजेडी, तो मैंने कहा एक काम करो, गीला टावल मुंह पे बांधो और एक जना उस एक तरफ से पकड़ लो, दूसरे के पास गैस मास्क है ही, लेके उसको फायर ब्रिगेड की गाड़ी में डालो और जाके किसी तालाब में डाल दो. दिस इज द ओनली वे आउट. तो कहने लगे साहब हालत तो देखिए, पास कौन जाएगा. तो मैंने कहा ना टावल बांध के चले जाओ. बोले साहब आप ज्ञान बहुत दे रहे हो, आप क्यों नहीं चले जाते. ठीक है मैं चला जाता हूँ. ये बात सही है कि अगर किसी को कुछ बताओ कि ऐसा कर लो तो कहेगा आप क्यों नहीं कर लेते, यू आर अफ्रेड ऑफ योर लाइफ. ठीक है मैं करता हूँ. मैंने टावल मुँह पर बांधी, साथ में फायर ब्रिगेड वाला गया, और ये वही पिक्चर है, ये मुँह पे कपड़ा टावल बना हुआ है, ये मैं हूँ. वो मास्क वाला आदमी फायर ब्रिगेड वाला है, उसको उसके ऊपर रखा और सायरन बजाता हुआ फायर ब्रिगेड का गाड़ी चला गया. I was faint in that process. I was hospitalized in Akshay Heart Hospital for a day. And सबसे बड़ी बात ये है कि ये पिक्चर जो रात में किसी फोटोग्राफर ने लिया था, ये न्यूयॉर्क टाइम्स में छपा. इसलिए नहीं कि मेरी तारीफ करनी थी, इसलिए छपा कि जहाँ पर MIC में हजारों आदमी मर गया, उस शहर में 2 गैस मास्क भी नहीं है. तो मेरा ये कहना है कि एक पैशन होना चाहिए ह्यूमैनिटी के लिए भी और अपने प्रोफेशन में भी. और आप पहले कैसे थे इससे कोई फर्क नहीं पड़ता, जब जागो जब सवेरा है. क्योंकि तो मुझे नहीं लगता था, मेरे टीचर ये कहते थे कि अगर बहुत कुछ हुआ तो किसी सेक्रेटरीट में बाबू बनेगा. जब मैं जापान से लौटा तो मेरी फ़ोटो देख के वो मुझे टाइम लेके मिलने आए, तो मेरी वाइफ से बोले कि मेरा तो ये थॉट था कि ये ज़्यादा से ज़्यादा क्लर्क बन पाएगा. एंड बाय द ग्रेस ऑफ माय पेरेंट्स एंड गॉड, आई हेडेड द स्टेट इन द फॉरेंसिक डिवीजन. तो हम न्याय के साक्षी हैं, क्या प्रथम सूचना प्रतिवेदन मिलता है, क्या FIR कहती है, क्या लोग कहते हैं, इससे हमें कोई फर्क नहीं पड़ता. What the physical evidence says at the scene of crime, that is important. और मैं खासतौर से हमारे यंगस्टर्स फॉरेंसिक के हैं कि हम न्याय के साक्षी हैं, क्या प्रथम सूचना प्रतिवेदन मिलता है, लोग क्या कहते हैं, एक हद तक मानना चाहिए, लेकिन फिजिकल एविडेंस जो बोलता है उस पर हमको ब्रूटली कार्रवाई करना चाहिए. एंड आई क्लोज माई डेलिब्रेशन विद लास्ट शेयर रिगार्डिंग फिजिकल एविडेंस कि अगर तुम अगर साथ मेरे तो मुझे गम किसका, आप ही मिल जाएगा हर मंजिले हस्ती का निशान. थैंक यू.
Thank you so much, sir, for very interesting and knowledgeable lecture. Now I would like to call Professor Dr. Darpan Bhargav, Surgical Specialist, TMJ Disorders, Clinical Director, TMJ Consultancy Services, South Asia, to deliver his lecture. So, enjoy
Only very few of you would understand this lecture and very few of you are present here, so we'll quickly finish the lecture as well. I think Dr. Prashant is there, being from Rishiraj College is there, Dr. Anisha Mali is there. So I think this lecture in particular focuses to the crowd in general, considering we need to get aware about certain things or something in particular area of subject. Now we have already spoken about the dead in the past. Each one of us are experts of our own fields. Dr. Jaju sitting here, he's working very well in Bhopal and around the place for cone beam CT scan. If some of you are dentists, you would understand that. Dr. Anisha Madia is there, she's working for oral maxillofacial surgery and upliftment for that. I chose a subject of a very small joint in the body, that is temporomandibular joint as such. This particular area is a specialized area in maxillofacial surgery. Although it was kind of no one's baby in the past, now we're trying to capture this baby because we've captured maxillofacial surgery from other fields of medicine, and now this is another area which if we don't capture, maybe someone else would capture it. So as maxillofacial surgeons, orthopedics never used to bother about this small joint in the body, and as maxillofacial surgeons we needed to get a little more trained in this area of expertise because we also did understand a little less about this particular joint. So my topic is more on temporomandibular joint, that is the joint in the facial structure. Uh, uh, I'm just looking at the crowd. If there's someone to hear, we can continue the lecture. Otherwise, wasting almost half an hour for that. Because Dr. Nishant is there, Dr. Anisha Maya, they are seniors to me in the field and they would know more than myself if they hear my lecture sitting here.
Going on of some students and all that. That was on half crowd is there. It is clashing in all this.
Anu just told me wait for a second, sir, let me arrange some participants for your speech. Okay, I will start. Okay, they are tight schedule for time also, so we can't wait on that aspect too. Now, when it comes to temporomandibular joint, it is a very common problem. Like now, I say that in a crowd of 100, if I pick up almost 25% of the crowd would have some kind of problem with their temporomandibular joints, some kind of pain, some kind of noises, and so forth and so on. So it is a major concern when you have a crowd of 100, you go to a mall and you pick up random 100 people and say 25 or 30 of them would tell you that I have this particular problem in my body. So that is the major issue that you are encountering and you are experiencing, that it is neglected. Now in this small crowd, if I can ask that any one of you have ever experienced that your jaw joint has pained or it has got some amount of noise which comes on and off and goes off, and then it becomes alright and we don't bother about it. Anyone? See one. So in a small crowd like this, you have a patient for me that ways that is sitting here, and I don't know whether she has seek help for it or not. I'm not sure about it, but she is my patient. So in such a small crowd, when you have one person who's sitting and raises his hand that I had this and I never bothered about it. But usually joint problems are a progressive set of problems if not intervened at the right time. Now, I look at the joint problems in my operatory as two major problems. One is called as the internal derangement of the temporomandibular joint, and second is the hypermobility disorders of the temporomandibular. These are the major set of problems which you would also encounter in your operatory if you see n number of patients. Now, it may not be easy to diagnose, but it is not very difficult to understand this, that most of the patients seek help only when they have pain in this area. Now, the commonest solution rendered at most clinics or areas would be, if you have pain, take a painkiller or a muscle relaxant and go off. That would be the commonest thing a doctor would prescribe you. Now, other than that, if you are a dental student, you would understand that this is another common solution rendered is giving off a splint therapy. When nothing works, you tend to resort to something like this, give some tense therapy in and around the muscles and the joint so that you maybe subside that problem for a certain period of time, or do some ultrasonographic massage therapy, or if nothing works, you do a minimal intervention somewhere in and around the joint and finish that problem at least temporarily. Now we should understand that this joint is a very small joint in the body and it works in very intricate synchrony. Now you understand that the joint in this area is controlled by a muscle and also a disc or a cushion which has to accompany this joint during function, accompanies the bony head of the condyle. That is, the bone has to be protected with a cushion all the time. When it is rest, the bone has to rest on a cushion. When it is in motion, the bone has to be covered by that cushion. The cushion also moves with a small slit of the same muscle, and both of them have to coordinate over function. So when you see a normal joint functioning, if you see this pink area here, that is the cushion to this joint, and when the bone moves, the cushion moves along with the joint, and at all points it has to cover the joint to protect it. And this is a wonderful picture which is also available on internet, where it shows the cushioning effect of the intervening disc of the temporomandibular joint. In case you get into this science, it gets more and more interesting that how this works, how this functions, and how you diagnose the problems with this particular joint. Now when I come to a specific patient and the patient tells me the problem, I have to imagine certain things. One is, you have a cushion in the center, you have the joint space, and you have the bones above and below it. Now I understand that when the joint moves, this cushion has to accompany the bone. Now there are two movements which are happening. When you open your mouth very minimally or slightly, you have a kind of rolling effect initially, which gives you the initial mouth opening, and then eventually the entire joint slides forward. That is the translation of the joint. Once the joint translates forward, the cushion has to accompany the joint surface. So you need to have some amount of translation onto the cushion or the disc which is there. Now what exactly happens is, if this arrangement is disturbed, that is the movement of the bone and the cushion, that is the disc, is disturbed, you call this problem as internal derangement. Internal derangement is disturbance in the synchrony within the movement of these structures. Now see, you have two bony surfaces that articulate. Now you have a disc in between. So you have two surfaces of the disc, superior and inferior, and you have the single muscle controlling the entire movement of both of them, along with the additional muscles that control. So one set of a problem into two, because you have two joints. So the problem, it can increase substantially, the incidence of the problem can increase substantially, because you have double the chances of having this problem. Now what happens in internal derangement of the temporomandibular joint is, if this is normal functioning of the joint, in the internal derangement of the temporomandibular joint, you would observe that the movement of the disc is altered and it does not move as desired, and gives you some amount of hindrance to the movement of the joint. This condition goes on to an advanced stage of disc displacement without reduction. You would see that the movement of the bone is hindered by the movement of the disc. Now, yet another problem which I was talking about is hypermobility disorder. Hypermobility disorder is a disorder where you see that the movement of the joint is so much that it stretches the normal tissues in and around the joint, and this is another cause of the pain which may be presented by the patient to you. So you need to distinguish these two things. In hypermobility disorders, you have to divide in terms of whether it is a soft tissue disorder or attrition of the hard tissues. So you need to make your diagnosis based on your imaging too. Now this is a clear case of hypermobility disorder, where you would see that if the joint is in a closed mouth position, you have the joint seating into the joint space properly, whereas when the patient opens the mouth, the joint almost jumps out of its limitation of space and goes and lies in front of the articular eminence. The eminence here, the bony protection, is called as the articular eminence. So this is a clear case of hypermobility. Now why I am highlighting this case here is, if you would understand that if this particular case is treated as internal derangement of temporomandibular joint, you would have failures, high rates of failures in your treatment. Now I would quickly jump to, now what we are trying to do is classifying all the temporomandibular joint disorders into various categories. That is, when the joint has no radiological abnormality but patient has pain. Now these are the patients who require treatment with medication and splint therapy, whereas from there onwards, when you have a physical problem in the joint, you experience a click, you experience a hindrance in the joint movement, or along with that you have pain. These are the areas which would require some amount of intervention. So based on the severity of the problem, you have minimal radiographic findings, and it progressively increases to a stage where your entire joint is altered, the joint structure is altered, and based on that you need to decide on the treatment protocols. Now according to the new norms, you understand that the conservative management is the management for only category 1 patients where you do not have any imaging abnormalities into the patient. But when you have imaging or functional abnormalities which set in within the joint space, you start considering it as a problem of any other joint in the body and compare to the orthopedic literature rather than generally the literature which is available to us. You don't want to leave a defunct joint to get progressively bad over a period of time, but do intervene at the right stages. To start with, the minimal intervention which currently is in practice is arthrosynthesis. Now arthrosynthesis is a procedure which is generally washing off the joint. It usually clears off the inflammatory mediators, and if there are any additions into the movement of the cushion which I had discussed, would eventually destroy those adhesions in the disc. Now what we have done is we've devised a technique where you do a joint lavage using a puncture needle, where you introduce the needle onto the joint space and then eventually you do lavage and lysis procedure to the joint with this single puncture needle. And wash out the joint with inflammatory mediators and the adhesions. Although this is more of as in a postgraduate level of discussion that why do we use single needle, no? But this is one of the modalities that we all should be aware about. Now another case which was conservatively managed and reported to me some time back was this, where patient had chronic locking episodes of the joint and patient had chronic pain for almost past 4 years. Now when patient reports you in such a chronic stage, you don't expect your conservative management strategies to work for such a patient. Now when we did the MRI scan for this particular patient, you see that the cushion which I talked about is lying in front of the condylar head, that is the bony prominence. Now once it is lying there, you understand that it has stuck somewhere and it is not moving. Now the oral surgeons here would understand this, that when I entered the joint space with arthroscope, this is what I saw inside the joint, that there was such strong woolly adhesions inside the joint space that any conservative modality will not help and resolve this problem. The treating physician, as in the treating person, kept the patient on splint therapy for more than 2.5 years, and then when everything didn't work, the patient reported back to us with such a dense fibrous adhesions within the joint space. You also observe that there is engorged vessels around the synovium, indicating severe inflammation within the joint space. Now I will skip all this. A normal joint usually on an arthroscope looks like this, very clear, where you can identify various structures. But when you have adhesions, you would have these woolly structures and you would have these engorged vessels which would indicate inflammation within the joint. Now arthroscopy usually works when arthrosynthesis or arthroscopy, simple washing away of the joint, usually works when you intervene with this within 4 weeks of the occurrence of the problem. But if you linger on with the problem beyond 4 weeks, now arthroscopy alone remains the option, where you want to get inside the joint space and see what is happening inside and then solve the problem within the joint. So this was about internal derangement. Now when we talk about subluxation, it is a problem where you have excessive mobility of the joint. Joint moves much more. Now this requires a very proper and apt diagnosis. If these cases are treated as internal derangement, usually you end up in failures. Now this I have already explained, so we'll just skip it. This is what happens at the end. If you observe this particular patient, you will see that when he opens and closes his mouth, his joint usually gets stuck at a certain stage and then closes. So he had hypermobility, eventually destruction of the joint structures, and he ended up in chronic locking episodes of the joint. This is one incident he had while opening and closing, when he had the lock joint when I was examining him. Then he self-manipulates the joint and reduces the joint. Now there are n number of modalities. The one simplest modality is a prolotherapeutic intervention to the ligaments of the joint, which is a very simple procedure, and which can be applied to these hypermobile joints. It just involves injection of certain agents within the joint and around the structures, which usually resolve the problem. Surgical management includes procedures like this, where you want to maybe down fracture the bone and then make a physical hindrance. Now I will skip all this. Moving on to other modalities which are there for the end stage joint diseases are now joint replacement surgeries, which are there. Now I will just go quickly to someone who has a doubt that why suddenly you're talking about joint replacement in temporomandibular joint related disorders. Now what exactly happened that every one of us would have heard already about knee replacement for our grannies or for the elderly people in and around, we know. But there was a mishap in the US where they used some wrong material in the joint. Now once they used the wrong material, there were a large number of failure rates. So we are quite late in this science. But now it is established science, and we can have this as a modality where you replace the entire joint system with a new total joint alloplastic prosthesis. Now I will skip all this because I think at this instance it may not be right to. Now this particular patient, I would show the radiograph first, that this is the patient who never opened his mouth for almost 8 years. He was a electric technician and he was on a pole doing something for his work, and then he fell off from there, and because he had no money he did not bother about the injury to his jaw, and eventually he had bilateral ankylosis of the temporomandibular joint, for whom we had done total joint replacement surgery bilaterally. Now just experience his words that how happy he is when he opens his mouth with a functional joint after say 8 years of not even having any mouth opening.
जैसे आपकी जबड़े के जोड़ का ऑपरेशन हुआ उसके बाद आप मुंह खोल पा रहे हो अच्छे से? हाँ हाँ बिल्कुल बिल्कुल सर. कितना खोल पा रहे हो खोल के दिखा दो. बंद करो. ठीक है. खाना वगैरह खा रहे हो अच्छे से आप? खाना भी बहुत बढ़िया से अच्छे से. पहले तो बिल्कुल भी नहीं खाया था. प्रेस करना पड़ता था हाथ से. बचपन से लेकर अब तक मतलब बहुत परेशानी में निकला. अब 1 साल होने को आया है आपकी सर्जरी को. अब खुश हो आप? बिल्कुल. मैं तो बहुत कॉन्फिडेंस में आया हूँ. पहले कॉन्फिडेंस भी नहीं था मेरे अंदर कि मैं किसी के सामने खा नहीं पाता था खाना, और आज मैं मतलब सबके सामने बीच में बैठ के खाना खा सकता हूँ. चलिए बहुत अच्छी बात है आप.
So this is the amount of change you can get into a patient in case you appropriately execute the right procedure for the right diagnosis. Now how it is done is, you see this particular patient with an ankylotic mass in the preauricular region, you replace the entire system with a functional joint. These are artificial materials which I am not going too much details into it, but this is another modality which is in practice for total joint replacement surgeries currently. Now this is kind of an intraoperative functional joint when you replace the entire joint system with a for a non-functional joint. So this is how the joint is fixed. This is how we close the joint, and these are the post-operative images of this particular patient. You would observe that immediately after the surgery, the patient is on the first day itself sitting in the post-operative phase and is able to function well. So with that, I would sum up, because I think this should be enough for the time and crowd we have. And although it is a great topic to have a great discussion, we would eventually meet up sometime later when we have some mass to listen to this. Thank you very much for patient listening. If anyone is interested, we do have copies. Dr. Anmol will, as in she wants to offer them as a gift to few of the prize winning candidates. They can go ahead and procure the copies from Dr. Anmol. Thank you very much. And I kept it very short, considering whoever is there interested, they will get back and they will get more information from us later.
Thank you so much, all the guest speakers, for your outstanding and enlightening lectures. We'll be having felicitation right away, so we'll take 10 minutes off.
Where are you guys?
I would like to call Dr. Kalyani Garge ma'am. I would like to call Dr. Harsh Sharma sir on the stage.
Projector off कर दो अगर picture भी ना come. और switch off your laptop.
I would like to call on the stage Professor Dr. J.S. Chandru. Manisha Maya ma'am. Dr. Prashant Chatterjee sir. Yes, I would like to call on Professor Dr. Tapan Bhargav sir. So, now I would like to call Dr. Vishwaraj Nikam sir on the stage. डॉक्टर करे आने का है ना Next, I would like to call Dr. Sarita Bhandari. Now I would like to call our very own host and speaker of the day, Dr. Anu Vashisht, to receive the honors. Thank you so much all the guest speakers for their outstanding and enlightening lectures. We will resume for the award ceremony sharp at 7:30 p.m. Thank you so much for gracing today's event with your presence.